Good morning, everyone. Hope you can hear me. Okay. Dear distinguished speakers, collaborators, esteemed guests, welcome to the third conference, healthcare conference organized by the American Chamber of Commerce and its Healthcare Committee. This year's theme is Driving Societal Value Through Healthcare, reflects our shared commitment to education and healthcare as key pillar for supporting human development, a vital asset for economical performance and sustainable growth. Our goal is to equip our workforce with essential skills and resources to navigate the challenges of a rapidly changing world. By prioritizing human capital development, North Macedonia will be better positioned to integrate into the single European market, building a foundation for long-term economic resilience and social prosperity. In today's dynamic environment marked by rapid technological changes, evolving geopolitical landscapes, it is essential for policymakers and corporate sector to collaborate. Together, we can improve living conditions and ensure our talent thrive within our borders, creating a society where health and productivity reinforce each other, generating lasting societal and economical values. The United Nations 17 SDGs, Sustainable Development Goals, provide a framework for our efforts. Of these, SDG 3, good health and well-being, is particularly relevant to today's discussions. According to a recent audit in North Macedonia, SDG 3 ranks second to last in terms of official development aid received, highlighting the urgent need to prioritize healthcare investment from all stakeholders. Achieving sustainable healthcare reform requires a national consensus and consistent policies that treat healthcare as a long-term strategy. We must shift the narrative to recognize healthcare as an investment in our country's future, a priority demanding action and cross-sectoral collaboration. I now leave the floor to our inspiring lineup of speakers who will bring their expertise and vision to important topics, providing insights and actionable steps that we hope will lead to a meaningful progress in North Macedonia's healthcare landscape. First among them, I would like to invite our chair of the Healthcare Committee, Valentina Mitrova, who will set the floor for discussion by presenting last year's recommendations. Thank you all for being here, and let's make this conference a milestone in our journey towards a healthier, more resilient North Macedonia. Thank you.
Благодарам Иван на најавата. Почитувани спикери, панелисти, представници на амбасадата на САД, драги колеги и соработници. Ми представува голема чест и задоволство во името на Комитетот за здравство при Американската стопанска комора и во моје лично име да ве поздравам и да ви се заблагодарам за вашето присуство на третата конференција за здравство на тема Потикнување на општествените вредности преку здравствена заштита. Како што напомена Иван на самиот почеток, би сакала да се навратам на кратко на втората здравствена конференција на AmCham, под наслов Поглед во иднината на нашиот здравствен систем, која беше организирана минатата година од страна на Комитетот за здравство при Американската стопанска комора. На овој настан беше истакната потребата од наша заедничка визија за здравствена заштита и здравствен систем достапен и правичен за сите. Втората конференција за здравство на AmCham беше навистина успешна и оценета како чекор напред во унапредување на мултисекторската соработка и партнерскиот пристап на сите креатори на здравствени политики со цел континуирано унапредување на здравството. На оваа конференција учествуваа повеќе од 20 експерти од областа на здравството, истакнати владени представници. Презентирани беа 2 извештаи на IQVIA и Open Data Institute со главен фокус достап до лекови како основен елемент на правото на здравје и вториот фокус употреба на податоци во здравството. Главната порака и принцип кој што произлезе од оваа конференција беше дека државата мора да гледа на здравството како приоритет преку обезбедување на еднаков пристап до квалитетни современи здравствени услуги за сите граѓани. За да се изгради одржлив здравствен систем, здравството мора да се гледа како инвестиција, а не како трошок. Овој принцип треба да биде водечки при носењето на сите одлуки од значење во здравството. Исто така беше потенцирана и важноста и потребата од преземање на следните чекори. Главен приоритет на здравствената политика во државата е ажурирање на позитивната листа на лекови со цел подобар и еднаков пристап до современи и квалитетни лекови. Согласно направените законски измени, да се искористи можноста за склучување на посебни договори со што ќе се оптимизира буџетот и ќе се создадат заштеди од планираниот државен буџет за лековите кои што се на позитивната листа на лекови, на товар на Фондот за здравствено осигурување, за лековите кои што се дел од програмата на Министерство за здравство, но секако и за лековите кои што се опфатени од условните буџети. Исто така беше истакната и важноста за дигитализација на здравството, како и потребата од национална стратегија за дигитално здравје. Сите представници кои што беа присутни на минатогодишната конференција, политичките партии и носителите на клучни одлуки се согласија дека треба да се вложат напори и да бидат посветени на подобрување на здравствениот систем со воспоставување на една заедничка меѓупартиска платформа која што ќе овозможи полесни диалози и решенија за најважните прашања и теми во здравството. На оваа конференција, меѓу останатото, беше истакната и потребата од формирање на Национален совет за здравство, кој што ќе функционира како еден форум или платформа за соработка во кој што ќе бидат вклучени сите креатори на здравствени политики со цел за континуирано унапредување на здравството. Денес, новогодишната конференција за здравство, која што доби карактер на традиционален настан во државата, има за цел да ги покрие следните теми. Влијанието и вредноста на инвестициите во здравството, односно како до еден сигурен, ефикасен и правичен здравствен систем. Друга тема на која што денес ќе се осврнеме е состојбата со незаразните болести во државата и потребата од стратегии и политики за незаразните болести. Кои се приоритетите на владата во насока на превенција на незаразните болести, имајќи во предвид дека сочинуваат висок процент од сите смртни случаи, некаде околу 95%. Ова ја нагласува потребата за зголемени инвестиции и национални политики за незаразни болести, како и од потребата за воспоставување на корисни алатки за следење на состојбите кај одредени заболувања, односно креирање на пациентски регистри, јасно дефинирање на патот на пациентот, како и да се обезбеди грижа каде што пациентот е во центарот, односно Patient Center Care. Кои клучни стратегии и иновации во здравствените системи во земјите во регионот се преземени за подобрување на пристапот до лекови и медицински помагала, како да се имплементираат добрите практики и решенија кои ќе обезбедат еднаков пристап до квалитетни и иновативни здравствени услуги во нашиот здравствен систем, ќе ни споделат во третиот панел регионалните представници од иновативната индустрија. Пред да започнеме со денешната конференција, би сакала да ги поздравам и присутните медиуми, кои денес се тука со нас и ја следат оваа конференција. Ви благодарам за вашето присуство и интерес, бидејќи вие сте еден од клучните фактори кои преку вистинско информирање и едукација на јавноста придонесувате за зголемување на свесноста и подобрување на здравствените политики. Токму во таа насока ми представува исклучително задоволство да ја најавам Академијата на новинари и серијата на сертифицирани обуки кои Комитетот за здравство на AmCham ги подготвува на најразлични теми од областа на здравството. Овие сесии ќе започнат од декември оваа година, за што дополнително ќе ве информираме. На самиот крај, но не помалку важно, сакам да изразам голема благодарност до сите членки на Комитетот за здравство, до тимот на Американската стопанска комора, Боган, Владко, Весна, воден од извршниот директор Елена Арсовска и сите партнери од приватниот сектор, кои што дадоа неизмерна поддршка и соработка со цел за успешна организација и реализација на оваа конференција. А сега ми представува чест и задоволство да го најавам главниот говорник на третата конференција за здравство, професорот Вим Грут, професор по здравствена економија на Мастрихт универзитетот од Холандија, кој ќе ни каже нешто повеќе за трансформативната моќ на здравството. It is with great pleasure that I would like to invite Professor Wim Groot, Professor of Health Economics on Maastricht University from Netherlands. Professor Groot, thank you very much for being here today with us. The floor is yours.
Dobro jutro. Thank you for your, Ms. Mitrova, for your kind introduction. It's a great pleasure and honor to be here with you today in your beautiful country. I must say it's my first visit here to Macedonia, and I'm very much impressed by all the statues here in the capital and all the other historical buildings here. The topic of my presentation and the message that I want to convey during my presentation is about the virtuous cycle between economic growth, economic development, productivity on the one hand, and health on the other hand. The two are essentially linked with each other. Increase each other and foster each other. The value of health goes beyond what it does to our quality of life and our life expectancy, but it also helps to develop economic capacity and productivity. That's the first part of my presentation. After that, I want to have a look at how Macedonia performs compared to other countries in the region. Basically my argument there is that especially when it comes to equity and accessibility in healthcare, I think there's improvements to be made in the healthcare sector in Macedonia, as it somewhat compares rather unfavorably to other countries in Europe, especially, but in the region as well. I'm an academic. So that means that I mostly look at evidence and available evidence. So most of my presentation will be based on presenting to you the results from academic studies and the synthesis of these studies in systematic reviews. It's essentially one study doesn't convey sufficient and compelling evidence of any relation. It's the multitude of studies, the multitude of evidence that makes relations compelling and provide sufficient evidence to generate and warrant conclusions about. And the first topic where I want to present some evidence upon is on the impact of health on productivity. What does health do to economic growth and the competitiveness of countries. And I do that by looking at a review study that has synthesized the evidence for the US, but I think all these the evidence can be translated and generalized to other countries, including Macedonia as well, on the impact of and the productivity loss of diseases and health conditions or health impairments. And this study synthesized close to 200 studies that have looked at the productivity loss of major diseases. What this study concludes is that especially pain and cancer are a major cause of productivity loss in our economy, or more specifically in the US economy. With the impact on the days of productivity lost, the days of absence from work because of the disease, ranging up to more than 450 days for the disease category. A second conclusion, if you look at this graph, shows the estimates from each single study on the impact of the disease on days of productivity lost. A second conclusion is that there is a wide heterogeneity, wide diversity between studies in the impact of disease on productivity loss. The same is if you quantify this on the impact of the amount of productivity lost. So the incremental cost of lost productivity of diseases, then you see that yeah, there's quite some variety, but most studies show that of these 5 conditions presented here: cancer, cardiovascular diseases, lung diseases, pain, and mental health diseases, depression. That most of these studies show that the productivity loss is up to $10,000 per year for workers suffering from these diseases. So this shows that there is substantial productivity loss associated with these most prevalent form of diseases that workers in working age suffer from. So this study concludes the synthesis of the evidence shows that the most common conditions that lead to productivity loss are pain and cancer. That cancer and cardiovascular disease can have productivity loss, can have an impact of up to 70% on work impairment and loss of productivity, and that most of the studies show that the annual loss of productivity is up to $10,000 per year. So this is this shows how impactful diseases can be on economic activity and productivity. Another way of looking at it is to compare countries in the impact of diseases and the cost, both the direct cost for treatment and the indirect cost in the form of productivity loss of different diseases. And the second study that I want to show you looks at the annual global burden of heart failure, quite a common disease with quite an impact also on workers, of people in working age. And this study looked at estimates at the country level of the estimated cost of heart failure within a different country. And this table shows some of the estimates of published studies of heart failure on both the direct cost, the cost for healthcare, and the indirect cost, the cost of including the cost, the loss of productivity. And if you summarize that, this study shows that the annual global burden of heart failure is more than 108 billion euros of dollars per year, with about 2/3 of that, or more than 60% of that, being direct cost for treatment of heart failure, and about 40% of the costs are indirect costs, mostly related to the loss of productivity of heart failure. Another piece of evidence showing how impactful health and diseases are on productivity and consequently also on standards of living and economic growth. So this, I think quite are two pieces of evidence showing what the impact is of health on our productivity. But there is also a reverse relation. We also know that there is a relation between income and productivity on the one hand, and health outcomes on the other hand. So the second set of studies that I want to show to you is on the impact of income and also income inequality on health and health outcomes. And the first one to do that is show a piece of my own work that again reviews the available evidence. In this case, the evidence on of income on health. What is the relation between impact and, in this case, perceived health outcomes or self-rated health outcomes in the population? And what we did here was reanalyzed studies conducted within countries to look at the impact of income on poor self-rated, self-assessed health. And this graph summarizes the main findings of this study. Each dot here is an estimate of the relation of income on self-rated poor health. So on the horizontal axis, we see income in percentiles, ranging from the 20% people with the lowest income to, on the right-hand side, the 20% people with the highest income. And on the vertical axis, we have the share of the population who rate themselves to be in poor health. And what you see here is a clear downward slope relation, implying that people with higher income are less likely to be in poor health. That is also shown by the estimates. We run also statistical analysis, regression analysis, relating income on the proportion of people in poor self-rated health. And you see, and we've done that for different European countries separately. And what is shown here is that in all these countries you see a very strong and negative relation between income and the proportion of people in poor self-rated health, also indicating that income is a major determinant preventing people to be in poor health, or otherwise that people with low income are more likely to be in poor health than people with higher income. Not only health itself has a relation with health outcome. Not only income itself has a relation with health outcomes, but also income inequality is shown in many studies to be related to health outcomes. And that is evidenced by this study that looked at the relation between income inequality in a country and health outcomes within that country. And what I found very illustrative was the graph that they present here, where they looked at the rate of income inequality in the country, defined as the ratio between the income of the 20% highest income earners in the country to the 20% lowest income earner in the country. And the higher this differential, the higher the income inequality, and an index of health and social problems in the country. And this index not only includes life expectancy and disease burden, but also more social indicators like distrust and social mobility, and the rate of incarceration and rate of homicide. So it's a broader index of social problems, including health problems in a country. And what this quite clearly shows is that based on these definitions, there is quite a strong positive relation between income inequality and this index of health and social problems in the country. With on the left-hand side, countries like Japan and Scandinavian countries, which have a very or rather low rate of income inequality, but also a low level of health and social problems within their country. And on the right-hand side, you have countries like the UK, but also Portugal, which have a much higher rate of income inequality, but also score much higher on this index of health and social problems. Again, this quite, is quite suggestive for the assertion that income inequality is associated with more health problems and more social problems in general. That is also, I think, that this is a more a general construct. It's also interesting to look at more specifically at the relation between income inequality and the prevalence of social problems at a more specific disease category. So this is maybe a graph that is a bit more difficult to interpret, but what it shows here is on the horizontal axis, the relation between diseases and the correlation between the diseases and median income in a country. So a standard of the income level in a country. And on the vertical axis is the same correlation between the disease category and income inequality in a country. And what it shows here that, for example, for some forms of cancers like breast cancer and prostate cancer, there's a very weak relation between these forms of cancer and median income. So it seems to be rather unrelated to the level of income in the country, and also very weakly related to income inequality in a country. On the other hand, if you go to the right-hand side of this graph, we look at, for example, respiratory diseases and heart diseases as health conditions, but also if you look at more broadly at social conditions, at homicide, you see that is much more strongly associated with or negatively associated with income, indicating that lower income of higher income means less of these diseases being prevalent in a country, but on the other hand, more positively related or associated with income inequality. So implying that the higher the income inequality in a country, the higher the rate of respiratory diseases, heart disease, and also homicide. So again, this shows a very strong relation between health conditions on the one hand and income inequality on the other side. Does that mean that investments in healthcare one-to-one translate in better health outcome? No, not necessarily so. That is evidenced by this graph, which sets out health expenditures per head of the population, per capita in a country, and life expectancy on the vertical axis. And what this quite nicely shows is that there is quite a strong positive relation between spending on healthcare and life expectancy as a health outcome, with a quite strong also correlation coefficient. But the effect seems not to be linear, but rather as a case of what we economists call diminishing returns. That at higher levels of healthcare spending per capita, the added value in the form of more years of life expectancy seems to be positive, but smaller than at low levels of healthcare spending. The reason for that is multifold. One thing is that at higher levels of spending, to increase outcomes, to increase life expectancy even further becomes more difficult. Requires more investment to obtain a similar increase in life expectancy than at lower levels of spending. The low-hanging fruit is already captured, and to add more to your life expectancy requires more investment. That's one element. Second element, the more countries spend on healthcare, the more they also spend on types of services in the healthcare system that not so much improve life expectancies, but rather are aimed at improving quality of life, more long-term care, more mental health care, for example, where the benefits not so much lie in increased life expectancy, but rather in better quality of life. And finally, what plays a role here is also the efficiency of the healthcare system. And there is also evidence that at higher levels of spending, efficiency within the system becomes less. And that is, for example, evidenced by the US, which is quite an outlier in this whole graph. It spends far more than any other country in the world on healthcare, but whose health outcomes, at least measured by life expectancy, is far below most other, especially European countries. But all in all, it seems to be that investing in healthcare does add to health outcomes, especially in the form of longer life expectancy. And that brings me on my final topic, how Macedonia performs on this compared to other countries in Europe and in the regions, and what can we say about the accessibility and affordability of healthcare in Macedonia compared to other countries. Because you can argue, as I hopefully have convinced you by arguing that there is a positive and virtuous relation between health and economic growth and productivity on the one hand, that investing in healthcare adds to this, to better health outcomes. But the question also is, is healthcare accessible for everyone who needs it? And is it also affordable for those who need to use healthcare? For this, I present some statistics from the OECD on healthcare spending and health outcomes. This, first of all, is a graph looking at healthcare spending as a share of GDP, of gross domestic product, for European countries, for EU countries, and some other non-EU countries. And Macedonia is there somewhere on the right. And according to these OECD statistics, Macedonia spends 7.2% in 2020 on healthcare as a percentage of GDP. And in that sense, it's if you compare to other countries in the region, it's a bit less than in Serbia. It's a bit more than in Albania, for example. So it definitely seems that, and if you compare it to Western European countries, you see that the Western European countries spend a larger share of their total national income on healthcare than countries here in the region. So there's definitely room for improvement in that. What is secondly most striking is that, especially compared to EU countries, Macedonia, that patients in Macedonia have to pay a far larger share of total cost themselves in the form of out-of-pocket payments, and that much less is being paid for collectively in the form of income transfers, either through the tax system or through the insurance, social insurance system, with in Macedonia up to 40% of total revenue for healthcare being paid for by out-of-pocket by patients themselves. And of course, out-of-pocket patients can be a barrier to access, especially for people with low income. That is also shown here in this graph, where the total spending on healthcare is differentiated by the source of funding for the or financing for the system, differentiating by compulsory contributions in either in taxes or in compulsory health insurance, voluntary health insurance, out-of-pocket payment, and other sources. And again, as I said, what is striking not only for Macedonia but also other countries here in the region, Greece, for example, but also Serbia, is that a relatively large part of the revenue come from patients themselves in the form of out-of-pocket payment. And again, out-of-pocket payment are a source of barrier of access to healthcare. Also fall more heavily, the burden of out-of-pocket payments fall more heavily on people with lower income. So it's also a source of inequality in the system if the share of out-of-pocket payment is high. And in this sense, Macedonia, as other countries in this region, compare more unfavorably to Western European countries, where the share of out-of-pocket payment is generally less than 15% of all payments for healthcare. Consequently, there's also that more people face a large financial burden if they need to access the system and need to use healthcare. That is expressed by the WHO in the form of the catastrophic payments for healthcare, and the catastrophic payments refer to the share of households who have to pay more than 20% of their annual income on cost for healthcare. And again, this shows the catastrophic, the share of households who have to pay catastrophic payments within the European Union and some other countries within Europe. And what you see here is that in Macedonia, roughly about 10% of the households face catastrophic payments, so have to pay more than 20% of their household income on healthcare within a specific year. And in that sense, Macedonia is among the countries with the highest rate of catastrophic payments within this European area. And these catastrophic payments provide a barrier to access and also are a source of inequality within the system. Does that then show itself or manifest itself in limits to access and unmet needs? Now that's a bit more difficult to say. There's limited evidence on the share of unmet needs in the system. This again is some statistics taken from the OECD that looked at unmet needs for medical examinations and dental examinations across European countries. And there you see that Macedonia is among the bottom of these tables, that compared to other countries in the in the region, but also compared to other countries within the European Union area, the rate of unmet need is not so high. If you look, for example, at the unmet needs for dental examinations, there you see this is differentiated between people with high income, where you expect the unmet need to be lower, and people with low income. Then you see that the unmet need for dental examination is roughly between 2 and 8%. At least that is based on the self-report of people about whether they, for financial, geographical, or waiting times, were unable to obtain a dental examination. And we see that other countries in the area, for example, Albania, this rate of unmet need is much higher than here in Macedonia. So in that respect, at least on these two outcomes, Macedonia seems to perform relatively well. This brings me to the conclusion, to the wrap-up of my presentation. What I hope to have convinced you about is that there is a virtuous cycle between productivity and health, that health and the absence of disease and a healthy workforce increases productivity, and that the productivity, consequently, the productivity losses related to diseases are substantial. And come on top of the direct cost for treatment of these diseases. That vice versa, there is a positive relation between income and health outcomes, with people with higher income being much less likely to be in poor health than people with low income. And that also there is a positive a relation between income inequality and health outcomes, with countries with more income inequality scoring worse on specific health outcomes. And if you relate that to to Macedonia, then we can conclude that the rate of the level of healthcare spending, or the relative share of GDP spent on healthcare in Macedonia, is relatively low, especially compared to Western Europe, but also compared to other countries in the region, for example, Serbia. That the rate of households, the share of households that faces catastrophic payments for healthcare is relatively high, providing barriers to access and limiting the affordability of seeking healthcare. But on the other hand, on the positive note, that the rate of unmet need here in the country seems to be fairly limited. And that is what I wanted to share with you. Thank you.
Good morning, everyone. My name is Boban from AmCham Executive Office. I have also pleasure to welcome you all. Dear Professor, thank you so much for joining us today and for providing such inspiring insights. It was truly an evidence-based presentation. Before introduction, our next keynote speaker, just please let me say that that we have made it easier to access some of our key documents that reflects our work. So on each table you can find a document which is titled Getting Ready for the EU Single Market, and also there is a key position paper on healthcare, which on your registration tag there is a QR code and you can access to them both as well. So I have now a pleasure to welcome Dr. Malina from Weifer Institute from Germany. She's going to provide additional insightful perspective on determining the impact and value of healthcare investment. Malina, thank you so much for joining, please.
Thank you for the introduction. Can you hear me properly? Yes, okay. So Thank you. I'm very honored to having today the chance to moderate the first panel or topic session. And I'm even more honored that I have the chance to start with a kind of impulse from my side around the topic determining the value and the impact of health investments. So yes, you should now see it. And the topic that I will talk about is, and this is also a take-home message that I have for you, is if you can measure it, you can fix it. So it will be around the economic impact of health investments during my session. Who am I? You've already introduced me via name. So I'm Marlena Müller. Müller, the second name, might already give you a hint that I'm really coming from Germany, because just I have received some questions if I am from Russia. So I know the origin of the name, but to be honest, I'm simply, how you would say it in Germany, a boring German potato. And Germany is also the funding city of the funding country of the institute I'm working for, and this is why for institute. We have 3 locations in Germany, 1 office in Athens, Greece, and besides that, we have people working for us in Latin America and in the US. At the moment, we are around 80 people, so 75 is not valid any longer. And we focus on 3 main research fields. First, impact analysis, international social policy, and health economics, where I am the head of, and why I have the pleasure to be here and also moderate the panel. We are working closely together with ministry, governments, associations, and also companies. And I want to share today some insights on how maybe we could all together contribute to seeing health as an investment. And I will do this in 3 chapters. First, I want to talk to you or with you about the paradigm shift that we need when we talk about health as an investment. Then I want to give you something by the hand, and that is the 3-stage health metrics that I think we should embed, before I then close with a conclusion and outlook, and we then start with the panel. So, paradigm shift, health as an investment. What do I exactly mean with that? So we as an institute, we want to foster a paradigm shift, and that is that spendings in the healthcare sector or spendings for health should not only be seen as a cost driver, but as a driver for growth, economic resilience, and prosperity. In a few years, I would love to say that in the past, healthcare was only solely being seen as a cost factor. However, it is unfortunately still the case, at least for most of the countries. What do I mean with that? It is a very input-oriented discussion. It is a thinking in silos, and when we talk about spendings for health, we most often talk about an increase in health expenditure that we cannot afford. I do not want to say that we don't have inefficiencies, but later more about that. But what we are neglecting is that the health economy is a sector per se. So spendings for health contribute to GDP, contribute to employment, and not only directly in the health economy, but along the whole value chain. This means that to create output, we have to work with other sectors to generate this output. So along the whole value chain, we create GDP and we create employment and overall contribute to better health. So the health economy should be seen as a sector and driver for growth and employment. While this narrative might already be compelling to some of you, it's not enough to only talk about this. What I would say is a no-brainer. We also have to measure it. We have to capture it, we have to quantify it, we have to find valid data or generate valid data to underline what we want to foster. And we are together with academia, but also with G20 partnership, we try to really bring this narrative to different stakeholders, to governments, to the industry, but also to NGOs. And in 2021, when Italy had the G20 presidency, we published a paper. It is called, If We Can't Measure It, We Can't Fix It. You might realize that I framed it a little bit more positive, and that is if we can measure it, we can fix it. And I do not want to talk too much about the details of this paper because you can read it. It's a little bit longer, but what I want to highlight is that in this paper, we suggested that the health economy should be seen as a whole social impact driver. And we see 5 main layers as an important step or value framework that we should see to address the rising global burden of disease. And if you look at those 5 layers, the first 3 layers are referring to the economic impact generated in a nation through spendings in the healthcare sector or in the health economy, what I mentioned, so that you have adjacent sectors that you need to produce an output, and that people who are then working not only in the health economy, but also in those adjacent sectors will receive a salary that can again go into the economy. Those are very simplified, the first 3 layers. The 4th layer is getting more and more important. It is the environmental impact of health investments. Today, I will not dive deeper into that, but what I will highlight a little bit more is the social impact of health investments in terms of what we have already heard. It leads to higher productivity. It leads to higher productivity that can again go into the economy. And while those 5 layers are already nice, I want to dive with you together into our 3 steps health metrics that we want to embed, or that we think we should embed. Because we have heard that, okay, spendings in the healthcare sector do not simply translate into a higher life expenditure, or that we have to think a little bit more. And this is what I have already mentioned. We are not, let's say, crazy. We know that the budget is limited, that we have scarce resources, that we have to invest in a smart way. And in order to do this, we need data that is tangible also for political stakeholders, that makes really a story that is understandable for, I would say, someone who is not a health economist and can understand all the data that we have already seen now. And in order to do this, we must capture the return on investment of health interventions. In the first step, we have to become aware and clear about the status of health in countries. While we know most often what are the main or leading causes of death, it is cancer, it is CVD, we often under-recognize the impact of diseases that have an impact on the quality of life. Nevertheless, this is also reducing the productivity of a country. So first, we really have to understand the need, because only when we know, okay, what are the most pressuring diseases in a country, we can really identify where should we prioritize the budget that we have, where should it go into. However, it is also important to capture the landscape of the current, let's say, interventions that we have overall to reduce this burden of disease. And it is not only about medical innovations or pharmaceuticals, but it is also about preventive measures. We have to start very early when we talk about health interventions. It's about increasing health literacy. It's about a general awareness about health per se. So this is also important, and we have to understand, what do we already have? How good does it work? To then, in the 3rd step, be honest about the return on investment of those specific investments. Because as I said, in the end, we have, at least so far, how it is structured, limited resources. But when we have the return on investment, this can also be inspiring for alternative financing schemes, because it could be a starting point for public-private partnerships, for social impact bonds, or other ways to finance health or interventions that could increase health in a nation. So I am really advocating for a holistic understanding of the health economy. So it should be, or it can be, a starting point for a new and objective dialogue between politicians, associations, but also companies. And when we combine the economic, environmental, and in the end, the social impact of the health economy, we have a starting point for evidence-based policy, because this is what we hear often. We have to do evidence-based policies. But especially when we talk about health, although data is getting better and better, I would not say that it is a really structured way of investing in this sector. So, to bring some numbers that you have an idea about how the economic impact of the health economy is, if we have a look at the global figures, those are the figures from 2019, the global health economy contributes with 6.3 trillion US dollars to the global GDP and supports 194 million jobs. As an industry that is most often not seen as an industry compared to, for example, the automotive industry, I would say that this is quite impressive. So 7.6% of the whole global GVA means it is twice the GDP of France. And the job creation combines the labor force of Canada and the US. So it makes it a little bit more tangible, I would say. But besides those economic impacts, we have also the increased productivity that Professor Groth has also already mentioned. What I would add is that we do not only have paid productivity that is increased with better health, but also unpaid work activities that can be done when you are healthy enough. In specifically Western European countries, we are talking about, can we increase the working time of our citizens? Maybe retirement age should be 67, 68, 69. But this is something we can only do when the people are healthy enough. And for everybody who has maybe a sick family member, a sick relative, a sick neighbor, or children, you know how important it is to have people below the retirement age that help you in your childcare, doing informal care. And this is what we often consider, not consider. We are always talking about the economic contribution, but unpaid work activities contribute to a big extent to the welfare of a society. What I want to show with this slide is that it is feasible. We can measure it, we can capture it. As long as we have information about the health footprint or the impact on health, we can then, with statistics that are available, capture the impact of health investments on paid and unpaid work activities. I would always say, the better the data, the better the outcome, the better the model. And this is what I would like to advocate for as well. Better data and data that is really harmonized also between countries, but it is feasible. And just to make it clear that the burden of the diseases, this is the money eater. It's not about the investments in health, might it be preventive strategies or measures or the medicines. It is the disease that is costing us the money. It is costing us the prosperity, and it is costing us resources, not only in the healthcare sector, but only in financial terms. For example, in Europe, CBD generate a socioeconomic burden that is equivalent to 4 to 5% of the European Union. Imagine if we could, with, for example, preventive strategies, just avoid half of those cardiovascular diseases or events. We have opportunity for more productivity, for more investment. So it creates, again, financial space when we really make it happen to avoid diseases, to tackle them. And while CVD is always kind of common knowledge, I think I have already mentioned this, some diseases are under-recognized. I brought an example here from migraine in Germany. What we did for the year 2017 was to estimate the socioeconomic burden of migraine in Germany. And we found that we lose yearly 547 million hours of paid work. This equals to almost 1% of all the hours worked in Germany. And while this is already, I think, impressive, it equals to 3% of the German GDP in 2017. This means, or is equivalent to the city of Munich 3 months not working. Nothing happening in the city of Munich, so one of the biggest cities in Germany. What is, I think, impressive for a disease that most often is considered as a, okay, you have a headache, you do not feel so well, but it has a real impact on the economy and on the prosperity. I'm already now going to the conclusion and the outlook. What I would like you to take home is that if we can measure it, we can fix it, but we have to work on that. Because we have to really allocate or optimize how we allocate our resources that are limited. We have to do this to promote evidence-based management of those limited, scarce resources. And when we have such figures and data, we can improve accountability, but also sustainability of health investments. Because in the end, it is also about predictability. And this is important, and because we have heard also in the beginning, something about the SDG Goal 3, when we talk about health investments, we are not only talking about the SDG Goal 3, we are also talking about SDG Goal 8 and 9, because better health creates or starts a positive feedback loop. And this is what we all should understand and what we should advocate for. And to close now with a citation from Dr. Tedros, already from 2017, is that we all have to work together to drive inclusive growth. And this is why I am so happy that today we have a topic where 3 different perspectives from government, from international organizations, and also the business come here to the stage to discuss this, because we all have to work together on that to see health as an investment. Thank you for now. This is it with my presentation. And I think now I can start with opening the panel. And I would like to welcome, where is he? Ah, here. Mr. Klikowski, please welcome. So, do you want to use this microphone? So, is it working?
I hope so.
Perfect.
Yes.
So, Mr. Klikowski, you are the director of the Health Insurance Fund of North Macedonia. And as far as I could find on the internet, you are committed to fostering transparency and accountability in the management of the public health funds. And you want to reduce the debts in the system. I think this is what characterizes you. If not, feel free to add.
Yeah, it's first I want to thanks to the invitation. It is a great honor and pleasure to be here. Thanks to AmCham for the invitation. Thank you for moderation. It will be pity if the work done in the health fund will be reduced to a few sentences. But I will shift to Macedonian now. Благодарам за поканата. Посебно ми е драго. Јас сум трети месец во Фондот за здравствено осигурување на Македонија и се надевам дека веќе сум доволно информиран да можам да се обратам и говорам пред една ваква сериозна источна публика. Тоа што Марина почна да говори се 3 кратки цели како што ги дефинирам јас, а тоа е сузбивање на корупција и криминал, за да се обезбеди повеќе здравствена заштита и подобри услови за работа. Овие се многу, условно кажам, може да бидат и краткорочни и среднорочни цели, меѓутоа јас не сакам да бегам од шалонот во собата и да не го спомнувам зборот на К, корупција и криминал во здравствениот систем и здравствена заштита, бидејќи јасно е дека голем дел од загубите во здравствениот систем се предизвикани од корупција и криминал, и без да го решиме тоа прашање, далеку ќе бидат овие теми тука што ги презентира почитуваниот професор Ималина. Okay.
Thank you. Is it working? Okay, so thank you for the introduction, and it makes it even more sad that unfortunately today we don't have a representative of the government here, although it would for sure enrich the discussion. But so we can see the positive side, and this is, you will have more time to bring your points in. And I would like to start with the first question, if this is okay.
Yes.
And this is from the perspective of the health insurance fund. What is your vision, maybe especially, as you said, after hearing or listening to those two sessions, when you think of North Macedonia's investments into the healthcare sector?
Кога Елена ми испрати агендата за настанот, издишав и си реков колку е темата далеку од нашите секојдневни проблеми. Не би сакал да досегам со затекнатата ситуација, меѓутоа бидејќи збориме за импакт, би сакал да кажам дека мојата институција има копи-паст план стратешки од 2015 година и веќе неколку години нема годишен план за работа. По ЕУ речникот во скоро сите подрачја или е статус-кво или сме во назадување од 2014 година. Секоја сте во една таква ситуација да говорите за импактот не само во здравството, туку и економскиот импакт е доста далечно. На добрата страна, во мојата долгогодишна кариера, 2/3 од мојот професионален живот работев за не за профит организација, Македонскиот центар за меѓународна соработка, каде што планирање, мониторинг, евалуација, ефикасност, ефективност, импакт беа дел од секојдневната работа, така да можам да разберам зашто треба и сакаме да збориме тука. Првото прашање е свесно за проблемот. Да, свесни сме за проблемот. Би дал неколку бројки. Значи, фондот за здравство во моментот ми се чини околу 780 милиони евра, од кои околу 11% се боледување. Значи, не зборам за долгорочни импакти, туку многу краткорочни импакти. И да се пофалам, само 1,5% од вкупниот фонд е за менеджмент на фондот и предпоставам дека сме една од поефикасните јавни институции. Меѓутоа и во здравствените услуги, кои се остатокот од 87% од овој фонд, над половината се за болнички лекувања, а сето друго е во останатата половина. Ми се чини дека од здравствените услуги околу 56% отпаѓаат на болнички лекувања. Исто така сме свесни дека посебно позитивната листа и лековите се значајно товар на најсиромашните граѓани и дека пристапот на сиромашните кон лекови и кон секако здравствени услуги е многу позначен отколку на побогатите 20%. И таа е состојбата. Оно што дополнително го оптеретува целата околина е дека институциите во здравството веќе повеќе години поред се третираат како ајде да не наведам никако како помалку важни, вообичаено се доделуваат на помалите коалициски партнери и дополнително на скоро една година се менуваат министрите и директорите. Кога се подготвував за мојата функција, сакав да воспоставам кои биле директори последните неколку години и тоа беше релативно долга листа на директори на здравственото осигурање во Македонија и во услови кои имате постојани кадровски промени, многу е тешко да се говори за стратегија и за импакт. Нашето здравство во такви услови функционира како противпожарна бригада. Значи, каде гори, таму се гаси. И кога действувате адхок и популистички, можем отворено да кажам, немате никакви цели, стратегии пред вас, нормално дека отсуствува планиран резултат. Мислам, не можеме да збориме за импакт, пошто за импакт можеме да имаме некаков план, бидејќи импактот започнува со планирање, а не започнува со мерење. Значи, во Македонија многу ретко се говори за 5 болести кои имаат највисок морбидитет и морталитет. Кардиоваскуларни, астма, хронична обструкција, на хронична обструктивна болест, хипотироидоза и други, диабет и други болести. Многу ретко се говори, многу често почесто говориме за други болести кои со морбидитетот и морталитетот многу помалку учествуваат. Бидејќи ако сакаме значајно да влијаеме на овие бројки, веројатно фокус треба да биде на големите бројки. Ово не треба да ги исклучи малите бројки или ретките болести. Меѓутоа, мораме да во јавните политики соодветно правиме и не да се движиме од настаните, туку да гледаме каде сакаме да стигнеме. И секако во овој пристап поместувањето кон постигнување импакт е многу тешко, бидејќи е многу по-фенси да купите ангиограф и да се слика министерот и директор на фондот со ново купениот ангиограф, отколку да инвестирате во превентивна заштита и ги убедите матичните и семејните доктори да посветат соодветно време на скрининг на луѓето, пациентите со можни ризици. Заради таквата состојба, ние имаме веројатно најголема смртност на дијализа во Европа. Имаме огромна смртност во првите 90 дена на започнување на дијализа. Мислам дека е над 20% смртноста на дијализа, а таа е таква затоа што пациентите доаѓаат веќе во терминална, мислам, во фаза каде што болест е крајно напредната. Нашите болници се преполни со компликации на диабет, дали офталмолошки, дали нефролошки, дали кардиоваскуларни, кои можеле да се предвидат. Мислам, не е тоа нешто што не може да го предвидите и планирате. И мислам дека овие аспекти мора да бидат земени во обзир. Ние соочени со предизвикот на неповолна демографија во Македонија. Значи, има се помалку население, се помалку способно население, се повеќе издржувано население. Проблемот нема да се реши со зголемување на придонеси, пошто тие што ќе плаќат придонеси ќе бидат релативно малку. Значи, ние мораме многу сериозно да ја погледнеме структурата на нашите трошоци во здравството, не заради импакт, туку заради обстанок. Значи, нашиот здравствен систем нема да обстане под притисокот на пад на продуктивно население и зголемени здравствени трошоци. Тука би застанал во момент, да.
Yeah, Thank you very much. So what I hear is kind of a seeking for a more strategic approach and a long-term goal. What do you see? Where do you see your role and the Ministry of Health role when it comes to such strategic goals? What would be needed in order to facilitate such a strategy or a long-term goal? And
Мислам дека прво владата и политичарите генерално, бидејќи мислам во првите говори беше спомнат некој консензус на политичките партии дека ни треба континуитет во политиката. Значи не може секој нов министр, секој нов директор да почнува од нула и бидејќи па мандатите кратко траат. Значи овие промени што сега ги дискутираме тука бајат 8 до 12 години, мислам. Ако имате еден ваков систем во моментот, не може да се смени во еден мандат, ниту во два мандати, камоли предпоставам дека за година дена ќе има реконструкција, па ќе имаме нови функционери и така натаму. Можеме да почнеме да го менуваме тоа и да институциите ги надминат, како да кажам, да ги надминат своите мали дуканџиња, македонците ќе ме разберат. Значи, ние не можеме да ги третираме нашите институции како мало дукенче кој ни е дадено на одговорност, па ние тука нешто си правиме, ние можеме да излеземе од тие рамки. И почнува со осознавање на проблемот. Една од работите што ме вознемири доста беше ревизорскиот извештај за клиниката на онкологија. И ревизорите, мислам дека гледам некои од ревизорите тука, напишале дека само 25% од пациентите биле третирани со биолошка терапија. Ја векам, во прва прилика ќе прашам 25% од што? Дали ние знаеме колку пациенти имаме? Дали имаме регистар на пациенти? Од тој регистар на пациенти, кои пациенти се подобни за третман со биолошка терапија? Не се сите пациенти со онколошка диагноза подобни за сите можни третмани. Зошто го спомнувам овој специфичен пример? Прво, затоа што се создава нереално очекување кај популацијата дека сите болни со рак треба да бидат третирани со лекови од 20.000 евра, што не е случај. Второ, затоа што ние не знаеме кој е состојбата. Надвор од регистарот за диабет и за ретки болести, ми се чини дека нема функционални регистри, има многу доктори тука, ќе ме коригираат, нема функционални регистри на другите болни. Ние говориме од рака, 7.000 болни со рак, 5.000 на онкологија. Мислам, кога ќе прашате кај се овие пациенти, од што се овие пациенти, добивате парчиња од одговорот, а не целосен одговор. И кога прашав зошто нема централен регистар за цистична фиброза и за онкологија, како што има за диабет и за ретки болести, одговорот беше па не ги фондот ги финансира тие набавки, а тој регистар е во Министерство за здравство. Ево еден од примерите за како тешко се поминуваат институцијските граници. Ако системот во мој термин функционира, не е важно кој финансира, не е важно дали е тој на Министерство за здравство или на Фондот за здравство. Мислам, јас би сакал мој термин да биде во Фондот за здравство, ама во моментот е ситуацијата како таква и ние мораме да се работуваме за да почнеме од базична работа, тоа е регистар на болни. Без регистар на болни не знаеме колкав е проблемот. И ќе биде све базирано на предпоставки, некои подобри, некои полоши. Едно од работите што сакав да ја сменам е во планирањето за 25-та, имав проблем да се објаснам дури со моето обкружување, е дека во апликациите што здравствените установи ги испраќаат до фондот, не ќем да гледам ампули, не ќем да гледам таблети. Ние morаме да се поместиме тоа. Јас морам да знам која е целната популација, за колку болни, колку пациенти говориме, колку тие пациенти ќе бидат третирани, пошто очигледно ако фондот е 800 милиони евра, а трошењето во здравство е милиарда и пол, дека не плаќаме све од јавни извори на финансирање, тогаш мора некоја одлука да се донесе колку пациенти од тие, дали има скоринг систем, како ќе се изберат, за со Оземпик на вистина да се третираат тие што имат потреба, а не директори и министри. И сега тука тоа бара поместување од размислувањето, бидејќи докторите размислуваат во ампули таблети. Сакам да се поместување кон размислување кон пациенти и колку ќе чини тоа лекување, за да видиме кои се ефектите. Како фонд ние мораме да бараме начин да добиеме без value for money. Најдобра можна вредност за парите, и тука соработката ќе е неопходна. Не е едноставно. Затвореноста на институциите е голем проблем, меѓутоа работиме на надминување на тоа. Прва задача ќе биде соработка на централните регистри. Мислам, без да знаеме кои се бројките, сето друго е шпекулативно.
So I think the audience liked your answer. I liked it as well, especially the part where you were focusing on cycle length and that you need better data. This is also something we discussed yesterday, that the focus is always on the cycle length of the current government. And I think the need for key metrics in the health sector should also help to overcome this. And you talked now about collaboration, and maybe, as a last question, how do you...
И кога зборам за стратегија, значи, канцелариите на повеќето македонци тука се полни со стратегии. Значи, не е дека ни фалат стратегии. Имаме национална развојна стратегија за следните 20 години. Имаме ваква, па таква. И морам да кажам, направени од скапи консултанти, и некои од стратегиите во кои јас сум учествувал биле околу $2 милиони да подготовката с учество на академија, на универзитети, на засегнати страни. Значи, не е недостатокот на хартии и документи кои ќе ги ставиме во библиотеките, туку разбирање што пишува во стратегиите е посветеност кон стратегиите, а за тоа мора да мериме и јавно објавуваме до кај сме стигнати со сето тоа. Пошто вака имаме необврзувачки стратегии кои ќе ги ставиме во полица, после не известуваме каде сме со прогресот и на крај чекаме Светска здравствена организација да објави извештај за да прочитаме каква е состојбата во Македонија.
Yeah. Thank you for clarifying this. So there is a need for implementation and action. One last question, and maybe you can try to give two short, let's say, statements, because you mentioned collaboration. How do you think that international organizations, but also business, can contribute to this?
Моето разбирање е дека комунизмот во Македонија уште не е мртов, Југославија уште не е мртва и приватниот сектор се гледа како public enemy, како јавен непријател. Морам да кажам дека на моите објави на социјалните медиуми најчесто сум критикуван заради мојата отвореност према приватниот сектор. 1/3 од мојата кариера, после оние 2/3 во не за профит, ми се во приватен сектор и имам 0 денови во јавен сектор. Надвор работа на стратегии и консултантски работи за јавниот сектор. Некојаш политичарите намерно потикнуваат тензија меѓу граѓаните и приватниот сектор, бидејќи некојаш треба scapegoat, жртвено јагне, да се обвини некој. Често обвинувањето е на очните газди, на болниците, на Или на некое друго место. Политичарите не се добри, јас сум сега политичар, не се добри во пронаоѓање вина во самите себе. За мене приватниот сектор е клучен партнер во обезбедување на здравствените услуги во Македонија. Крајната цел е да граѓаните, пациентите добијат најдобри можни здравствени услуги, каде што кој ќе е операторот на услугите не треба да биде предмет на дискриминација, туку треба да биде еднаков третман. И во фондот е таков концептот. Нашите ценовници важат и за јавните и за приватните партнери. Јас го разбирам очекувањето на македонската јавност дека треба јавното здравство да се засили и работиме заедно со Министерството многу на тоа. Меѓутоа има сегменти каде што јавното здравство не може да ги намали ниту на среднорочни патеки времењата на чекање. Таква е кардиохирургијата, офталмологијата и уште неколку подрачја. Се поакутно ќе биде прашањето на диагностиката. Еве зошто сега еден од најекспонираните јавни примери е буџетот на онкологија, колку пари има за онкологија и дали пациентите ќе имат редовна терапија. Многу малку се говори за диагностиката и за фоллоапот. Македонија прави само 2500 скена годишно на 5000 предпоставени болни од рак. Хрватска, спрема моите информации, прави негде 22.000 пет скена, кои се важни и во диагностиката и во следењето. Да не зборам дека во одредени диагностики на онкологија листата, времето на чекање е малку подолго од што би сакале. Сега, кога инвестирате десетици милиони евра во иновативни биолошки лекови, а диагностиката касни и тешко е да следите дали таа има ефекти, е малку повторно трошење на јавни средства од прилика. И мислам дека и тука приватниот сектор мора да се отвориме. Значи, ова не е дали ја го сакам или не го сакам приватниот сектор. Едноставно мора да се отвориме кон приватниот сектор и да обезбедиме повеќе услуги кои ни се неопходни во овој момент. Секако, многу често македонската јавност заборава дека всушност најголем дел од здравствената мрежа е приватна. Примарната здравствена мрежа е приватна, поголем дел од секундарната здравствена мрежа е приватна, сите аптеки се приватни и многу често, има само, веројатно тебе да има помалку, има само 109 јавни здравствени установи, веројатно и 50 би биле доволни за 1,5 милион луѓе. Значи, ние често забраваме дека всушност најголем дел од операторите во здравството се секако приватни и треба да го надминеме тој јавен анимозитет и да ги создадиме можностите, бидејќи за мене како центар десно политичар најважно е граѓаните тука да добиват здравствена заштита. Дали ќе биде јавна или приватна здравствена заштита е седно до граѓаните тука добиваат неопходната здравствена заштита и моја цел е да го намалиме драстично лекувањето во странство со отварање кон приватните болници и со носење на странски експерти во Македонија за да се градат капацитетите на нашето здравство, без разлика дали е приватно или јавно. Деновиве еден македонски кардиолог се враќа од Словенија, ќе почне да работи во македонска приватна болница. Зошто да не го поздравиме тоа, ако можеме да обезбедиме во земјата дополнителни услуги?
Thank you very very much. It was very impressive, especially how you see the business sector. And while the business sector will have later also some time here on the panel, I want to thank you before.
Знам, времето истече, ама ќе ми дадете уште 5 минути, сакав да се рефлектирам на неколку работи што беа кажани претходно. Беше спомната позитивната листа. Таа е за прв пат сменета по 2014 година. И само за да сите стекнате впечаток кој е состојбата, ранит единот кој 2019 треба да биде забранет и да биде тргнат на позитивната листа, се уште на позитивна листа, а фамот единот кој треба да биде на позитивна листа, се уште не е на позитивна листа. Значи, 2019 е забраната. 5 години не е коригирана забрана на позитивна листа и ние имаме забрана директно на позитивна листа. Отворени сме за разумни вклучување на нови лекови во позитивната листа, каде што треба да си решиме некои дилеми. Дали да отвориме место за нови поскапи лекови, бидејќи тие се теретот во сиромашните, а да избришиме некои од лековите што се лесно достапни и што месечна терапија чини помалку од една пакова цигара. И сега тоа треба политиката да го одговори. Втората работа што сакав да ја спомнам се посебните договори. Македонија донесе измени закон и донесе упатство за посебни договори од 2019 и ме убедува во Биро за јавни набавки дека има одредби, дека може да се вршат набавки, некои ги викат Managed Entry Agreements, некои ги викат MAP, во Македонија се викат посебни договори. И ме убедува во Биро за јавни набавки дека имаме сега обезбедена процедура и треба така да оди. Фактот дека од 2019 до сега во 5 години ниеден лек не е поминал таа процедура, збори дека процедурата е невозможна. Значи, постоење на процедура која е невозможна е како да нема процедура. Мислам, ќе ги интересира дел од луѓето што ги гледам во првите маси. Во однос на планирањето, планирам за прв пат да ги поканам фармацевските куќи да предложат алтернативен поглед на буџетот. И пациентските организации. Договорено. Затоа што ми се чини дека има една, јас сум доктор по образование, некам колегите да ме разберат погрешно, но има една инерција во напуштањето на стари практики. 15 години се употребуваат off-label лекови кои може да бидат заменети со нешто друго. Поврзано со позитивната листа, да кажам дека го менуваме системот на e-рецепт. Изумив да го кажам како пример за неопходна соработка, каде што ќе можеме да ги поврзиме специјалистичките извештаи од мој термин со e-рецепт, за да ја скратиме администрацијата и за матичните доктори, и за аптеките, и за пациентите, а и работата во фонд да ја намалиме. И само да најавам дека оваа година алтернативниот буџет и буџетот сакаме што поскоро да го завршиме, за да буџетите од bottom-up ги координираме со нашите барања пред владата и пред Министерството за финанси. И во моментот го имаме побарано најхраброто зголемување на буџет во последните години. Можам да кажам дека бараме буџет од 53 милиарди денари за оваа година, 24-та беше 46 милиарди денари. Сега во евро не можам или во долари брзо да тоа ќе биде околу 900 милиони долари, претпоставувам. 58 е денеска доларот. Значи, овие неколку податоци да ги споделам, за да мислам дека ќе бидат корисни. Се извинувам што е надвор темата, ама сакав да рефлектирам неколку работи.
Thank you. I think we have no time for questions, unfortunately. So maybe you can, during the coffee break, clarify it.
No, vine se dada informația, dar am minut, ea și merge la atenția ta țară de contribuții. Și scuza, dar nimeni s-a până pe cele sau auditorium, de că la pozitivna lista može bi nekoj propišuvali raniti tim. Raniti tim svite bezbednostne informacije, koji što bez obzira da li ima na sajtu Tinajeva, no za koje što nije poznavamo i te nije prožiti. Ще веднаш на веб страната на агенцията тие информации се публикуваат, уште веднаш се известуваат сите здравствени работници дека тој лек нема да се пропишува и тој се повлекува од промет. Значи, останувањето на тој лек на листата е, значи, има техничка работа.
Значи, да нема погрешно недоразбирање. Ранит единот е се уште на позитивна листа. Ја не реков дека се препишува. А последицата дека фамот единот не е на позитивна листа и дека болниците треба да бидат посебно одобрување со еден куп администрација во фондот, за да им го употребиме, да го дозволиме употреба на лекот што е замена. Не реков дека се препишува, да бидеме јасни.
Hello. Unfortunately, the translation was not working, but I think it's a rather intensive topic. Maybe you can discuss this during coffee, because we have limited time also for the other participants from the international organizations and the business sector. Thank you very much for your input. I learned a lot, and have a nice rest of the day.
Thank you.
So, shall I? Better than this?
Yeah, this will be here for.
Hello. I understood. So, okay, we're already transforming ourselves, and we now have, during the same topic, and that is the impact and the value of healthcare investments, representatives from international organizations. And I think, I don't know, we will not have a break. We will directly start. So I would like to welcome from UN, Ms. Rita Columbia, and from WHO, Dr. Ali. So in this session, we will discuss why international partnerships are crucial for strengthening North Macedonia's health system, and how we can shift the perspective from seeing healthcare as a cost to recognizing them as an investment. Welcome. You can sit wherever you want. Okay. So first I want to introduce you a little bit more. So Ms. Rita Columbia is UN Resident Coordinator in North Macedonia. Welcome. She is dedicated to improving public health outcomes in the region through her experience in international development and humanitarian assistance. And Dr. Ali, you are a WHO representative in North Macedonia, and you are committed to strengthening the health system through collaboration with the government and ongoing reforms, building on nearly 3 decades of experience and successful partnership. So I will open this panel with questions that you both will receive, and I will start with asking you, can you describe the role of your organization, the role your organization play when it comes to strengthening the healthcare system here in North Macedonia?
I can, if it works. It works, okay, great. Is it still good morning? As I was introduced, I'm Rita Columbia. I'm also a medical doctor, and of course, I'm not practicing now for some quite time, but when you doctor, you remain a doctor, at least for your family. So you can imagine I'm still a family doctor for my kids, for my parents, and for the rest. And I do believe that the universal access to healthcare is vital. If we don't have health, we don't have anything. So it's the health and the right to health care is the foundation of sustainable development goals. It's a foundation for happy life and long life. And if we look at the definition of health, which is given by WHO, it's a complete physical, mental, social well-being, and not only the absence of disease. If we look at that definition, what UN family is doing in this country, it's exactly about health, because we are working in different areas to improve well-being of people of North Macedonia in their physical health. So by promoting the healthy lifestyle through our agencies, starting from the school and going throughout the life course. And it's in addition to WHO, it's also UNICEF, UNFPA, to some degree UNDP, IOM, they're all working in these areas. So mental health is very important, and the factors that affect mental health, they are critical, but sometimes we don't even notice them. How much stress do we have every day? How can we cope with the stress? So what are we doing to improve our lives? That's everything comes back to us as health. So if I ask today, all of you, how many of you have been stressed today, just this morning? Well, I've been stressed because I was late for one of my meetings. And each stress give us some of the element of illness in a way that will lead us accumulative to much bigger troubles. Going back to what UN is doing, so that's exactly what we are doing to make sure that there is a positive, there is a productive, there is a healthy environment for people of North Macedonia and the country. We're doing it through our cooperation framework, which is called UN Sustainable Development Cooperation Framework. This framework owned not only by UN family, but also by all stakeholders in North Macedonia. So we have a separate outcome or high-level result in that framework that refers specifically for quality of services, which is about healthcare, but it's also about education. It's also about social services. And then the rest, we have also environment, we have economy development. It's all, at the end of the day, it's all relates to the well-being of people. Personally, I prefer to look at health more in a comprehensive way and more from the point of preventing diseases rather than to deal with what we have. Because that's to deal with the diseases more expensive than to prevent them. And that's why when we speak about health of people and healthcare services system, we really need to look at both ends. So prevention and then curative medicine and how it worked together.
Thank you very much. So I would say the focus is, or one focus area is indeed mental health, what is getting more and more important.
At the end of the day, mental health, what keeps us moving.
Yeah. True. Thank you. So, Dr. Ali, same question to you. What do you, can you describe the current role that your organization play here in North Macedonia and maybe also highlight the key areas or your focus areas?
Thank you. This is working right. Yeah. Okay. Good morning. My name is AmCham Ali. I work with WHO as the representative to North Macedonia. I've been here since July in your beautiful country. Fantastic place, good people. Thanks for welcoming me and thanks for inviting me today. WHO is the specialized health agency for the UN. So our job is to translate the global ambition that the UN has in achieving Sustainable Development Goal number 3 and all the ones that are related that you and Vim already highlighted. It's our job to facilitate the delivery of those goals with member states like North Macedonia. And we've been here since 1996. So we have a long journey behind and possibly ahead of us in working with the government to achieve those goals. If you ask me, where do we focus? I think Sasha really made it very, very clear in his conversation with you. Healthcare that is accessible universally, equally, in an affordable way to everyone that needs it. That's the big challenge that we have across the globe. It's the UN ambition to achieve universal healthcare. North Macedonia wants to achieve the same. WHO is here to support North Macedonia in making that a reality. That's the first big task. To do that, obviously, we have to tackle the big priorities in terms of healthcare outcomes. One of them being non-communicable diseases. And on that level, it's both exactly what Sasha was saying, diagnosing at the right time, providing the right optimal treatment, supporting beyond the initial treatment, and more crucially, as Rita just said, preventing those non-communicable diseases in the first instance, because many are avoidable, which therefore means that we, of course, focus on mental well-being, the use of alcohol, harmfully and otherwise, use of tobacco, but also the things that we can do that would improve people's well-being. Work, surprisingly, is a good thing to have for your well-being. At the same time, the other areas that traditionally you might not have related to health, from transport to energy, to the way we manage our waste, which therefore impacts on the environment. I think you said it very clearly, Melina, also impacts on health. And so WHO work with the government in those areas as well. The one thing I would want to underline as part of the work we do that is absolutely important is preparing for incidents that can threaten our well-being. I think COVID-19 was a very good testament to the adage, without health, there's no prosperity, without health, there's no peace, without peace, there's no health. And what every government needs to do to prepare for incidents that might happen, and also to be able to respond appropriately when such incidents happen. The so-called health security is another key area of work that WHO is partnering with the government of North Macedonia and the people of North Macedonia to make sure we are at the right place in terms of efforts regarding that.
Thank you very much. And just because it's such a good fit, before I will ask you again the question, I have mentioned it as well that WHO has recognized that health is an investment a long time ago. However, we are still really trying to foster really this paradigm shift. And so from your point of view, why do you think is the narrative that health is a cost driver so persistent? And what can we do or do better to really see health as what it is, as you have mentioned, the basis for kind of everything? Very easy question, I think.
Yeah, thanks, Marlena. Such an easy question for me to answer. Where should I start? I've worked in 17, 18 different health systems across the globe, and we have this debate and conversations every time. In each context, the peculiarities, the way things are organized, the way people focus on the issue changes one form or the other. However, the critical issues are kind of the same everywhere. And I really liked what you, Malina, and Vim set out right at the beginning, giving us the perspective about data. I'll say two things first. One, data is not enough. Because if it is, we will not be having this conversation. Secondly, the ability to shift mindset has to start from within. And that's why what Sasha was saying earlier on about how the health insurance fund here wants to operate and how it will operate in the immediate future is critical to what I'm just about to say. So, health is a cost in terms of healthcare provision. There's no arguing it. It costs a lot of money. However, if you think about it in terms of health as a tool for personal growth, community emancipation, social development, economic growth and prosperity, as Vim was saying, then you shift the focus of the conversation. However, you have one big challenge to that. I'll speak jargon for just a second. Allocative inefficiency. And Sasha put it very clearly. If you're spending money at the tail end of healthcare, where actually people are diagnosed late, people have come at the point at which what they need is rehabilitation that will just manage quality of life, as Bim was saying, then of course health will be a cost. If you start from just treatment, you don't look at preventing illness in the first instance, health will be a cost. So there is first the challenge of allocating our efforts, our monies, our time in a very efficient way. Start with what works to prevent illness if we can. Easier said than done. Then the next bit for me is a disconnection between the various sectors that health impact on. So when we think about health, as you show, we look at how much we're spending in the health sector and how much we spend on medicines, on hospitals. We forget that people work in hospitals, so therefore they earn salaries and bring money into the economy. Innovation in medicine and medical care and healthcare and well-being generates employment elsewhere. What we do in terms of managing the logistics of healthcare, bringing goods from one end of the country to the other, generates economic activity. We forget about all of that in the equation. So when we start, oh, the hospital costs several billion, we can't afford it. Actually, there is that disconnect that we need to work through. Again, easier said than done. When you, I think it was Sasha that was just saying it, when you have a community where the interest groups, the lobbying groups, the social salience is all about fancy new equipment, fancy big shiny buildings. There's nobody agitating for tobacco control or reduced alcohol use or better mental health at the moment. Because actually those big shiny things are more important for people and for, dare I say, the political cycle, because they're short term and people want to see results pretty quickly. So what we need to do, even those of us who work in health, I don't think we've got it right yet, is to understand the narrative that will give people the full end of the story. Where you start from in terms of what you put in, what you get out, and what you get out, what it means. So all that bit about indirect costs, we need to get it done better. Lastly, there's a lot of uncertainty about the return on investment. And it's very difficult to prove a negative. As a public health practitioner, I sometimes find it very difficult to explain to people what I do. I say, the day that you have to deal with emergencies, outbreaks, that's when you know what I do. When we get it right, because we've vaccinated the right groups of people, because we've done the good work in education of children and women, and we've supported obstetric care and gynecological care and mental health care in the right way, and people are flourishing, you don't know what we do. But when those things don't go right, however, it's not a direct line always between what we do and the results. And that uncertainty is very, very difficult to explain in very simple terms to our political leaders, to our policymakers, to the people who hold the purse string to determine what we spend money on. And that's the bit where a big dialogue that involves the community about what we cherish, what we think is important, and how we balance that importance with what we want to achieve for humanity, and particularly in North Macedonia, I think will be important. So we need to get the political narrative right. We need to get the financial narrative right. But also we have to have a dose of optimism. Thank you.
I like this. So optimism. With great optimism, I'm coming to you to bring another.
It's like plus and minus. Go ahead.
To bring another question. So you mentioned that, yeah, indeed, health is a cost, especially when it happens only at the end of the, let's say, patient journey. So we need access to diagnostic, to preventive measures, but we need this in the whole, let's say, society. So I would like to ask you about healthcare equity and access to healthcare based on your experience and also maybe in other countries. What do you think could North Macedonia do to increase health equity and access to not only innovative medicines, but yeah, to preventive measures and diagnostics as well?
Yeah, thank you. Thank you for the question. There is no one recipe for everyone how to make it work. So we have industrialized countries who are well developed, still having problems with the universal access to healthcare. Look at the United States of America, for example, as one of the examples. If we look at the more positive example of Canada, they do have universal access, but the waiting time is very long there as well. So there is nothing that goes only positive. There is always pros and cons. And as Akim mentioned, we really need to look at the country's context and look at the commitments at the political level, also the commitment and understanding of the issue at the community level. So the easy answer would be, okay, all people of North Macedonia should know from the very early age how to live healthy lives, how to prevent non-communicable diseases, how to prevent communicable diseases, how to be healthy, for example, for girls and women, how to be healthy in during pregnancies, how to be healthy mother, having healthy motherhood. So how to bring up healthy children. So we're supposed to know that, but most of us, we don't until we face a health issue. So then the recipe becomes like with multiple ingredients. It means that the health issue is not only Ministry of Health and Health Insurance Fund supposed to deal with. It's a multi-sectoral issue. You have education sector here, you have social protection, demography, let's not forget about that. And I'm still new, a little bit new in the country, only 1.5 months, but I already noticed how much politicians, government officials, civil society organizations speak about demographic trends in the country. So, but again, even if we have data, let's use the data to do projections. Let's see how many people and where they are and what kind of disabilities they may have, using the demographic projections, using that kind of tool that UN has. We have UN agencies that can help, like UNSC, for example, that, or WHO as well can do that, the mapping of the services, but also together with other agencies to see where you have the most vulnerable population, how many of them of which age, how many of them will require certain services. So again, it's multi-sectorial issues. Of course, we cannot go without financial resources. And what I noticed in that short period of time, that budget gets cut when it comes to prevention. For example, just recently, I received a letter about cut of the budget for HIV programs. So HIV, it's not a problem that went away, disappeared. It's still here. So it's in the country, it's in the region, it's in the world. Not to make this issue like epidemic. We need to prevent. We need to work on prevention. So cutting budget on this specific issue may be a good solution for the short term, but not very strategically smart for the long term. So again, it's all about our choices, what choices we make. Okay, we have limited budget, but then let's make sure the choices that in the long term will not bring more problems and actually more spending. As Akim mentioned, and I also repeat myself, that prevention costs much less than treatment. So about innovations, again, working around the world, I have seen many things innovative. Before coming to North Macedonia, I was in South Korea. You can't imagine how medical treatment and prophylactics there, at which level. So they actually do it per capita, like everybody should go through these prophylactics checkpoints, what do you call it, checkups, yes, checkups. Every single person in the country goes through this yearly checkups, covered by the national insurance. So apparently they found it much cheaper, and Akim was in South Korea, so he can either agree or disagree with me. I was a client of that kind of treatment. I'll tell you, I got checkup from the bottom of my head to my feet in 3 hours. Every single procedure that exists for checking up, I did that, 3 hours. So, and when I asked my colleagues, I said, this is very expensive, you know? And they said, no, but national insurance covers it, because at the end of the day, it is cheaper to invest in checkup than to treat cancer, than to treat cardiovascular diseases, than to treat diabetes and the rest. So again, it's all about choices we make. It's all about how we use the financial resources that we have strategically. We spoke about digitalization, and that's actually what is needed for North Macedonia. We need to bring digitalization to the health sector, not only with the data, but also with the services. Akim and we spoke about telemedicine the other day. So this is, in many countries, it became the practice, especially during COVID. So it became the practice, and it's something that can be replicated here as well. Let me stop here because we're already out of time. Thank you.
Thank you very much. I have directly a question for you that follows up. I think what I've already heard from both of you, or what is unfortunately true for most of the countries, is that there is no glory in prevention, because especially when it works, nobody knows it. But when you think now of the state of the healthcare sector here in North Macedonia in 5 years, okay, you said you're only here for 1.5 months, but I would presume that you have a vision, and how would it look like?
Well, if I dream about it, I would say first that the population is healthy. Let's start with that. That the kids learn in school how to be healthy, that there is a control over tobacco products, alcohol products as well. So I would love to see that. I would love to see also that the access to services is available for everyone, not only for those people who have insurance and who lives in the cities and who can afford additional services health services, but also for Roma population, for those who live in rural areas where you don't have primary health care point to go. So I really want to see the network of health providers being strong, and also I want to see integrated services. Sometimes we don't need 10 people in one place. If we go for integrated services, we can also reduce cost of services. Of course, the quality needs to be assessed, and that's another thing. That when we speak about quality of services, it's important not only for the medical people to understand what are the standards and criteria, what are the protocols, but also for the clients. For people like me, if I go to the doctor, I want to know what he or she is supposed to do to me, and what will be like at that level of good quality should be provided to me. So education for population on the quality is important as well.
Thank you. Hakim, I have the same question for you, kind of. So we have already heard that, yeah, the vision is to have a healthy or healthier population with better access and, yeah, a properly working network with the stakeholders. And besides your vision for North Macedonia in 5 years, I would also be interested to see how you think your organization can maybe contribute to fostering such a working network, especially based on your long experience.
Thank you. Well, am I allowed to be greedy? I want everything Rita wants.
Yes,
Yeah.
let's go.
I want everything Rita wants plus. I think there's an important point that Sasha made earlier on that really does need emphasizing and underlining for North Macedonia. The civil service or public servant or public service infrastructure that will maintain continuity in healthcare and the other sectors is paramount. And in 5 years, I think actually 5 years is too far away. Yesterday, we should have a strong, flourishing, well-supported public service that focuses on how to achieve these lofty goals that we've just been describing for the people of North Macedonia. I think that would be a very, very powerful ambition, and it's achievable. You've got the minds, you've got the people. Yes, some of them might be in the diaspora. It's possible to bring a very formidable public service ethos into the way we deliver services. Of course, championed by political agenda, supported by our political leaders, about the choices we make about resources. I think for me, that would be an important vision to achieve. The second bit is how the community engages with healthcare providers, with policymakers, with the insurance fund. So it's not seen as, oh, let me just grab the bit that is for me and for my family. Actually, it's the entirety of the community having a debate about where do we invest our energy together. Meet halfway. If we are going to prevent stroke from causing adult disability, if we are going to reduce the amount of mental health anguish that our young people experience, if we're going to reduce cancers, HIV transmission, TB, actually we have to do the right things at the community level as well. And therefore that engagement in a systematic way to have conversations about what's important to every community in North Macedonia, I think I would like to see that so we can make some really important decisions. And lastly, find the right way to get the right amount of resources into healthcare. That would be really good. Yeah. Yes, please add it.
You forgot one thing.
Please add it.
Aging. We are getting to that point, you and I, and probably many people here as well, that active aging should be a priority. And seeing people who have access to programs on active aging, including the health as well, which is the most important. I think that would help not only longevity, but also economic growth of this country. So young people, they will go, they will leave us, parents. So they have to, because they want to learn what's happening in the world. Besides, North Macedonia is in the heart of Europe. Why not? But then who stay in this country? People like us. So we don't want to be useless. We want to be useful for the society. For that, we need to be healthy, right? We need to be active. And that's where I would like also to see the government putting some resources and efforts. Yes?
Aging well in good health is one of the priorities for WHO in the region and would be definitely one of the things that we would want to do with North Macedonia. Thank you.
Thank you very much to both of you. So I would say that you are indeed needed, and especially with your vision, and I hope then also actionable, and powerful collaboration in the future contribute to this vision. But as we have already heard, we need an active network, and this includes also, although there seems to be some hesitancy, the business sector. And this is why I want to now welcome our representatives from the business sector. The idea is to hear a little bit how can the business sector contribute to advancing healthcare, especially innovations, but also contribute to a also functionable collaboration with government to improve health outcomes. So please say hello to Mr. François Destois and Mr. Siko Mukateho. I hope I pronounced it properly. So, welcome. Welcome. So, Mr. François Destois is pharma area head at Roche and has extensive experience in driving pharmaceutical innovation and enhancing patient access to medications. And Mr. Siko Mukatov, Zhivko, pardon, is the CEO of Alkaloid AD in Skopje. So you are leading one of the largest pharmaceutical companies in North Macedonia, dedicated to advancing also the local production and innovation in the healthcare sector. Thank you for being here. As in the recent panel or session of this panel, I would like to start with a question to both of you. I would start with you, and then you will receive the same question. And the question is, how does your company perceive the concept of the societal value of healthcare, and what does your company do to create such a value at a societal level?
Thank you very much. Thanks for having me today. I feel very honored and privileged. It also coincides with my very first visit to Macedonia. And as Dr. Ali has said, people are extremely friendly, very inviting. So far, so good. I'm also grateful for the keynote speakers and for the other panelists, and especially for the education on a day in the life of the Healthcare Insurance Fund of Macedonia. I found that extremely rewarding. Thank you very much. So I think the position of Roche would be that the concept of societal value is a cornerstone, is an absolute must for future sustainable healthcare systems. We absolutely have to move the conversation from costs to value. We have to move from cost per patient per year. That is a construct that kind of follows the annual budget cycle of governments and companies to something that looks a little bit more longer term related to that impact. Roche certainly believes that a healthy population is foundational for having a vibrant community and for having a solid economy, very similar to what many of the panelists have spoken about. And knowing this, whenever we have an opportunity to engage with government and policymakers, we certainly encourage them to not think about healthcare and innovation investments as a cost, but think them as a way to invest into the future and to ensure this economic and communal stability. So your question then is, what does Roche do particularly? And I think I'm going to be representing all multinational pharma companies here, or at least partially, in what I'm going to say now, because we do share a lot of things in common. So in Roche, we're certainly very committed to creating, and especially co-creating, a healthier future along the patient journey, so end to end. And how we do that is to discover, development, and bring forward innovative medicines or medical innovations in order to improve their outcome for patients, so they live longer, they live better lives, and therefore make a very, very large contribution to societal health. In trying to achieve this, we are very focused on our investments around innovation and along a broad front of things that might not always be that obvious. First of all, as a company, we invest about 14 billion euro a year in research and development in order to search for that next standard of care, especially in disease areas of high unmet need. And we do it increasingly more to lead us to prevention. And in those disease areas where it is possible, holding a very lofty goal of cure at the same time. We also try through our investments to match patients to treatments, to see that we can, on the one hand, certainly take waste out of the system, but more importantly, that we with more certainty can help patients understand that they will benefit from that. We also follow them through the journey, through monitoring, to make sure that they continue to benefit from those treatments. On the other hand, we also invest in patient convenience. There has been thoughts shared around home care, decentralized care, by offering technologies like prefilled syringes, subcut formulations, on-body injectors. We certainly allow and enable that more and more to happen. We invest in innovation and go-to-market models. How do we bring medicines into countries? And a very important part of that is managing the entry of those innovations into countries through innovative pricing and reimbursement schemes. And maybe very relevant to today's conversation, trying to be extremely innovative in how we engage with the stakeholders in healthcare. How do we come together to deeply understand the problems we are trying to solve and put what is not an immaterial amount of experience that we've all gained in that stakeholder group to solve for these. It always surprises me, and very positively, that when we come together with a single purpose and bring all those things to bear, invariably solve the problem, the COVID situation being a very good example of that. And I think very similar to all organizations, we set ourselves very lofty goals. At the moment, we're aiming to deliver 20 transformative medicines in diseases of the highest unmet need by the end of the decade. And so far, so good.
Thank you very much. Switching over to you. What do you think about the societal value of medical innovations or treatments?
Thank you very much, first of all, for inviting me on this event. Ladies and gentlemen, it's really a pleasure and honor to be present on the conference. And thank you for the leadership of the AmCham for organizing this event. Alcalit is a company that employs more than 3,000 people. And from this perspective, it's a company which is one of the biggest, let's say, employers in Macedonia. We are one of the biggest taxpayers in the country and company which have more than 1,000 suppliers which are living and existing and functioning here in Macedonia. And from this perspective, it is clear that we have a huge responsibility towards the society and the community in which we live. During the years, we went through different, let's say, phases and activities and examples of how the company was trying to make this extra value for the society. 16 years ago, we opened a foundation, Traice Mukhaetov, which is giving scholarships to the best students from pharmaceutical and medical faculty. We already gave these scholarships to 659 students. 101 already are working in the company. and we invested more than 130 million dinars until now in this foundation. Also through different auspices of the foundation, we organized 10 humanitarian events in which we gave more than 10 million dinars, mostly to healthcare institutions, to environmental NGOs, and SOS Children Village. When the COVID pandemic started, AmCham was the first company which gave a donation to the Ministry of Health of 200,000 euros in that time. After that, we donated over 155,000 euros to the General Hospital in Kavadarci. So I would like to say that from this perspective, the company is definitely a partner to the health fund, to the health institutions, and all the, let's say, activities which are related to that, I would say, in the society. In this moment, we are working on two projects of arranging refurbishments of two clinics in the complex of Mother Teresa in Skopje. So these are practically continuous endeavors, and I would like to say that it's for every country, it's really important to have a domestic production, especially in the time of crisis, because we know how the situation was in that time. Let's say many companies who are very generous were not very generous to our country and to our citizens in that period, but AmCham was here as some stable part of our community. Last but not least, I would emphasize the generic pharmaceutical companies. AmCham is a generic pharmaceutical company. We are key partners of the healthcare system for stable and sustainable supply of pharmaceutical products. And we are always with superior quality for the affordable price, something which is, I think, needed, especially having in mind that the, let's say, the financial position of our citizens here. The global pharmaceutical market in 2023 was estimated, I suppose, as nearly $1.6 trillion. Innovation companies, originators have substantial share in the overall consumption. Every innovative pharmaceutical product that enters the market is a result, we are absolutely aware of, an extensive development procedure, which is subject to patent protection. But after the patent falls, I think that definitely the generic companies are here that can imply substantial savings for the healthcare system. So I think definitely we need this synergy of all the, let's say, members of the system so that the service for the citizens could and should develop in a better way.
Thank you for pointing also the importance of generics out. Yeah. I will directly follow up with a question to you, and this is how you, however, at your company, what are you doing to implement or to foster innovation? Because having a look at your ESG report, you seem to be really committed to a long-term and a sustainable perspective. And how do you also outbalance the similar maybe to health is a cost, those in a first step maybe high investments into such policies or practices? How do you approach this?
Thank you very much. Well, AmCham is committed to continuous sustainable development and adherence to comprehensive ESG practice. We started to work on formal ESG reports from 2022, and AmCham was the first company in the country which officially published the ESG report from 2002 until now. And it is, I would say, part of the culture of functioning of the company. Concerning the investments in research and development, until 2009, we had one segment in the company which was, let's say, research and development segment. But from 2009, from the scratch, we built a new institute for research and development. In this moment, around 200 scientists are working in our R&D institute, and we are very proud of the team which works in this segment of the company. In recent years, AmCham has embarked on a process of redesigning of existing pharmaceutical products for the new indications. We are especially very proud. We had goal in the past, but what we achieved in the meantime, that's this development of value-added medicines that address the treatment and fulfill the needs of individuals or specific patient groups. Strategic investments aimed at modernizing the product portfolio, and we developed and we patented the first value-added medicine in the company. That's liquid-to-liquid omeprazole, for which we already sold licenses to the partners in EU, which are in the countries in which we don't have a field force. And we are very proud that in the last few months we already made the first releases to the markets in United Kingdom, to Ireland, and to Netherlands. One of our top strategic goals is definitely to differentiate through the knowledge of the employees in the company and through the research of value-added products. And of course, implementing something which nobody mentioned here, which is high ethical standards, which I think are very important for our industry, credibility and professional approach in the overall operations of the activities of the people and any company. And one other thing which I think is key for everything, that's the people. Employing and retaining the best people everywhere in the countries in which we are functioning is one of the key priorities of the company. We are dedicated to sustainable corporate practices, eco-friendly design, environmental education, circular economy, which we are practicing a lot, renewable energy utilization, and sustainable development embodies the strategic objective of the company towards fostering a sustainable future for both the company and the society we live and work in. The environmental agenda, no matter, how costly it may seem, when compared to the efficiency, effectiveness, and optimization of processes, not to mention environmental protection, is definitely something which is worth investment. We are absolutely trying to even convince the others, which are part of the industry sector of the economy, that they should much more focus on this segment, because I think that's the only way that it could put us on the path that we could be more competitive globally. Thank you.
Thank you. This is a strong commitment. And this brings me back to you. You said that you're committed to value to society, first of all, by going into the market or into the region. And you mentioned that you brought 20 transformative medicines to the market.
We're on our way.
How do you have examples how you bring innovation to the region, or do you have a good example of how maybe partnerships have contributed to really bring the medicines to patients?
Thank you. That's a great question. And as Dr. Ali said, how much time do you have? I just want to get quickly, before I get back to your response to the first question, and just recognize that in the healthcare environment, there is space for innovative medicines as well as generics. Both those will help solve the healthcare issues of the world. So I'm in full agreement with that. I also, just dawned on me, I probably need to explain citrus a little bit. I'm not sure how many people are familiar with the construct of citrus, other than it being a lot of alphabet letters. But roughly, it is a part of the world that starts with Bosnia in the west, goes all the way to Bangladesh in the east, Russia north to Turkey in the south. It covers about a third of the world's population, and I would even say disproportionately contributes to the unmet need across the world. It's a very diverse region, as you can imagine, but as Dr. Ali has said, there's probably a lot more that's common in all of those healthcare investments that we care to recognize. And the one thing that is common is that we all have the same pursuit, and that pursuit is to give early, broad, and sustainable access to patients to the medicines that they can benefit from. Your question is also kind of timely. Just this morning, I received an update on the successes we've had as a region across this year on things around policy and access. And it might surprise you to realize it spanned about 20 pages of successes. And all of them, without exception, was results of collaboration. None of them was a consequence of an individual or an organization thinking it's a good idea and doing it. It was all collaborations with stakeholders across the healthcare environment. For 2025, we've identified 90 conditions that we want to collaborate and co-create on across the area to further enhance access and policy initiatives to underlie that access. So we're doing great also in Macedonia, but there's still a hell of a lot more to do. And we're going to be trying. We're going to be trying. So some examples, maybe go to Georgia very briefly. Even though they have universal healthcare coverage, they still had huge gaps in treatment of cancer. We very recently there signed with the payer a basket agreement in oncology to provide coverage for the whole Roche oncology portfolio, and it serves as a platform for new innovations to be attached to as they become available. So these things are possible. They're not just dreams. Serbia, I think, is another great example. We've had managed entry agreements in Serbia as long back as 2016, and they've certainly led to reimbursement lists being updated periodically, but they never broke the camel's back, so to speak. So there was a pivot to more policy-related work, working with patient advocacy groups, working with sectors around healthcare, not just in healthcare itself, as we mentioned before, working with oncologists and others. And the conclusion of that was that oncology was elevated to being a priority for the government, and the Ministry of Finance released about 61 million euro to be utilized for innovative healthcare. And since then, 22 innovations have been recognized through that funding, and 17 of them in oncology. We quite frequently, in order to give experience and to test some proof of concepts, we sign memorandums of understanding in disease areas like ophthalmology, multiple sclerosis, to give everybody an opportunity to try, learn, and see to what extent we want to embed that in healthcare. And if you allow me a minute, maybe I can bring it closer to home a bit and talk about Macedonia, since we are in Macedonia. And I'm very impressed by the progress of healthcare in Macedonia. And I don't want to marginalize the challenges that we have, that we heard so eloquently about earlier. But there has been great progress made to make medicines available, both innovative medicines and generic medicines. But it's also true that often these medicines are made available through conditional funding. And that's a really good start, and we should recognize that. But the dialogue has to continue to make sure that we offer these treatments more sustainably in order to not leave any patients behind, which is certainly a personal passion of mine, but probably more importantly, not to start people on treatments and then ultimately have to take them off because these treatments no longer fit the condition or the funding. So managed entry agreements, there's a good framework for that. We heard that. A reimbursement list, there is a process to have that updated. And as far as managed entry agreements exist, that's a good starting point. But sustainability, you'll only always achieve through getting products on a reimbursement list. And then very importantly, that has to coincide with things like updating your treatment protocols. It has to coincide with having an efficient procurement system. It has to coincide with having a credible and maybe a slightly more comprehensive health technology assessment system. And it certainly requires us to apply ourselves in finance and data management more effectively. It's only when all those things come together nicely that you start moving towards mastery in healthcare. Are we on a good track?
Yeah, it's nice to underline also the progress that has already been made, where I think North Macedonia, must not hide. So you said it's not a dream, it can work, although it is hard. But when we're already talking about dreams, what is your vision for healthcare in North Macedonia?
I tend not to have visions by country. We have
then the region.
We have global ambitions, but they do have country level application because things are and can be quite different. And maybe before I look forward, I need to look back just for a second and just reflect on Roche's legacy over time. And this legacy is built primarily, and what we are known for by most people, on investing in innovation. And we've covered that. But the other thing that we are also known for is our global presence. We are present in 140 countries globally, including here in Macedonia for the last 25 years. And that has been through thick and thin. And our intent is to continue to be present in those countries, to continue to be present in Macedonia, and be the valued partner in future that we have been up until now, working with various stakeholders. So a commitment towards healthcare and patients in Macedonia. So I do think just generally, we can spend a lot of time talking about visions and ambitions and how Roche represent that. But based on the topic for today, maybe the way I can most eloquently articulate it is that healthcare and innovative medicines has to be recognized as a foundational element for resilient, for vibrant communities and for stable or growing economy. Healthcare investment or spend cannot be seen as a cost. It has to be seen as an investment in the future. We have lived with environments that look at healthcare as a cost for too long, and we have great experience with the shortcomings of that. So it's a strategic investment in national productivity, in societal health. It contributes to economic growth that was so eloquently put forward by Professor Groot. And at the end of all of that, there are long-term and sustainable savings for the healthcare environment and for the local economy. But my vision for Macedonia, based on the knowledge I have, and I'm here to learn a lot more, certainly, but based on what I know now, is that healthcare needs to be continued to be prioritized and built into the annual planning and financial cycles. And the Ministry of Health and the Ministry of Finance needs to be in lockstep and converse, collaborate on an ongoing basis. And by the way, I'm not saying that that's not happening. I'm just saying that even if it's happening, it could possibly happen more. We talked about data a lot, and I think making continuous progress on digitalization, being able to collect that data, being able to analyze it, and then be able to utilize it to support the notion of societal value is critically important. But then also to bring those proof of concepts, that evidence, into your day-to-day decision-taking as you think about bringing innovation or medicines to patients. So it should be taken into your health technology assessments ultimately. Otherwise, it's just data. Dr. Ali said it, data alone is not enough. It has to be fairly utilized. And then something that Roche is very passionate about is that we have to be patient-centric. Healthcare needs to be patient-centric. And my sense is that in Macedonia, healthcare is very centralized. So don't shoot me if I got that wrong. But there's certainly an opportunity to bring healthcare closer to the patient, closer to the caregiver. Think about decentralized care. I think telemedicine was mentioned earlier, but home care is certainly a trend that we want to support as an innovative organization. And through all of that, you get secondary or peripheral benefits of just reducing the burden of your infrastructure, your hospitals, your staff, your doctors and your nurses. So that's in a nutshell.
Thank you very much. One last question to you before we have to close this session, right? Yeah.
I can see that, there is a wish for coffee.
Yeah, I think so, yeah. But just, you mentioned collaboration during specifically the pandemic situation. And as you underlined, we have already talked a lot about dreams and visions. Maybe you can, take a minute to discuss a little bit in a more concrete manner, how could such partnerships look like that help to foster collaboration?
Thank you. Well, first, globally, we are all aware about the challenges which are, let's say, facing every health system. We are talking about the aging of the population, new infections, bacteria resistance, epidemics, and many other things. So that's something which also is a challenge for Macedonia, of course. On the other side, as the director of fund mentioned before, we have a lot of, I would say, silos in the system which are not integrated from the point of data. And I absolutely agree that we need to have this integration of the information, so the data of course, from this perspective, after that, we can make the right conclusions and we can go to action from the point of what we have as some base. The point is that the health should somehow become priority in the country from the point of the politics of every government, I would say. It's a fact that it wasn't the case until now, and now we're hoping that it will take the, let's say, position in the pedestal, which can after that really make the health system something which, of which we will, you know, after some time we will be proud, because in this moment we are aware that we have a lot of challenges and a lot of history, which is, I would say, very, very, very tricky from the point of what we should talk about that. We are all partners in the system. We are all stakeholders in the system from the perspective of many, I would say, angles, from the perspective of producer, from the perspective of patient, from the perspective of all the people who are involved, because on the end of the day, we are all patients on the end of the, let's say, after some time. And really, I think that our health system should be smartly dimensioned on one side. On the other side, it should be, of course, balance, having in mind the financial condition. We can't make radical changes, but the start is, I would say, very fine. We have extension of the reimbursement list. We have opening of doors that some other new generations of medicines should be somehow afforded to our citizens. And if we all work inclusively together, if every individual and also as a teams, as I would say, parts of society put some extra brick, I think that we should make a system which will be, I would say, efficient, much more than what is the situation now, resilient and sustainable for a longer run. Thank you.
Thank you very much. Thanks to both of you and also to the other three panelists. I think we are all ready for the coffee break. Just 1 minute, I want to try to summarize those broad perspectives about determining the impact or impact and value of healthcare investments. I think what we have kind of heard in almost all of the three sessions is that we need strong partnerships, we need data, we must also analyze the data and draw our conclusions. And with the strong partnerships, I think we really have to build trust, what is very important, also for an honest discussion about inefficiencies when we talk about spendings in the healthcare sector, and also see the progress, the good progress that already happened. So also for a little bit self-confidence, maybe. And in the end, it is about the patient, and we want the patients, that could also be us, to be healthy and then contribute to a healthy economy as well. Thank you for all the perspectives and your insights. Enjoy the coffee.
Brief, we are getting back in 15, actually 12:45 to be here. We appreciate that. Thank you.
Dobar dan.
Jer čuje sve ok? Zdravo.
Ja vas čujem sve. Čujete li mene?
Da, sve ok. Samo moment.
Ok.
Jer sada čuješ sve ok?
Super.
Super, mi vidimo tebe, čujemo tebe, tako da vraćamo se za 15 minuta. Jer to je ok?
Odlično.
Hvala.
Bog.
A healthier future. That's what drives us. And as the world evolves, so do we. For over 125 years, we have taken on some of the most complex challenges in healthcare, listening and responding to the ever-changing needs of people around the world. We focus on the long term, leading investment in research and development, striving to improve lives today and for generations to come. We're advancing science to ensure everyone has access to the healthcare they need. Always innovating, we bring together dedicated people and diverse perspectives from across our global network, empowering each other to break new ground. But we can't do it alone. To succeed, we collaborate with each other, with our partners, with governments, with patients. Proud of what we do, we're here because we care. Our work creates a future where we all have more time with the people we love. That's what makes us who we are. That's what makes us Roche.
Да, готово baš. Добре, брат. Може би ще това да помютнем, да не ги микрофония да не стане. Да не стане микрофония, да.
Test.
Всичко. 1, 2, 3. Buongiorno. Добре.
Test, test, test. Prova. Dobro.
Dobro.
Dvojka. Test. Test, test, test. Dobro?
A healthier future. That's what drives us. And as the world evolves, so do we. For over 125 years, we have taken on some of the most complex challenges in healthcare, listening and responding to the ever-changing needs of people around the world. We focus on the long term, leading investment in research and development, striving to improve lives today and for generations to come. We're advancing science to ensure everyone has access to the healthcare they need. Always innovating, we bring together dedicated people and diverse perspectives from across our global network, empowering each other to keep breaking new ground. But we can't do it alone. To succeed, we collaborate with each other, with our partners, with governments, with patients. Proud of what we do. We're here because we care. Our work creates a future where we all have more time with the people we love. That's what makes us who we are. That's what makes us Roche.
Okay, ladies and gentlemen, we are beginning with the next session of our healthcare conference. It's true that we are a bit behind the schedule, but I'm sure we all believe that it was worth for it. So it's my pleasure to introduce our next keynote speaker, Mr. Arkady. The floor is yours.
Disturbance, I believe. Okay, here I have the good day to you all. Hopefully you had your coffee. Boban informed me that I'll have between 10 and 12 minutes for my small keynote, so I prepared around 50 slides for your convenience in order for you to be happy. But that's why I said hopefully you had your coffee. Just kidding, of course. My name is Arkady. I'm former advisor to 3 health ministries in Bulgaria. I'm a healthcare economist. I'm a consultant, and blah, 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 blah. And I'm here to speak about prioritizing non-communicable diseases, urgency, strategies, and solutions, and addressing the challenges in North Macedonia. Economic overview, because the economy is an important part of our lives. Basically, everyday interactions are based on economic decisions, no matter if they involve money or not. There was this quote, "The economy is stupid," which was used back in the 1992 by Jim Crowley, who was a strategist for Bill Clinton's presidential campaign back then. So the economy is stupid, the economy arises more and more. And yesterday we saw in the elections that it's one of the main priorities of the ones that elect our government. So the economy is in a bit of a turmoil due to the inflation that we have. If we are speaking about North Macedonia, the economy expanded by 2.3% in the second quarter of 2024 compared to the same period in the previous year. Inflation rate, the annual inflation rate was projected at 4%, which is good because it dropped down from previous times. The problematic area could be the unemployment rate, that is continuing to be at a rather high percentage compared to all the other countries in the region. And of course, the percentage of GDP in 2021, current health expenditure was 8.52 of the GDP. And of course, colleagues beforehand spoke about the out-of-pocket expenditure, which I think you cannot see fully. The out-of-pocket expenditure in 2019 was approximately estimated at 40%, which is almost half of expenditure in health comes out of the pockets of the North Macedonian patient. This is a graph that I did for the average EU expenditure in healthcare. You see it, of course, in 2020, it rises up. It's due to COVID and due to many other reasons, but now it's continuing to have such a high trend. Intentionally, I have given an example with North Macedonia and Bulgaria there, that the percentages of healthcare spending, private and public, are more or less the common in the past couple of years. Of course, keeping in mind that there are factors for those non-communicable diseases, you know, the global local impact of non-communicable disease is responsible for 71% of all deaths globally. In North Macedonia, it causes nearly 90% of all deaths, which is a very high percentage. And this is due to environmental factors, air pollution. You know, in the winter times, we have the same problem in Sofia. At some point there, you can cut it with a knife. It's a problem and it needs to be addressed. The other one is lifestyle and behavioral factors. In the Balkans, we all like to drink nice alcohol. We like to have fatty foods, and we don't like to exercise so much. So another factor for spread and such a huge amount of non-communicable diseases is the lifestyle and behavioral factors. Of course, socioeconomic healthcare factors, which are also an important part of the daily life. Poverty leads to bad health, leads to communicable diseases and also non-communicable diseases as a high percentage. And especially, how should I say, as you very well know, inflation is a hidden tax, and it can induce poverty, and it can induce other also political and economic tensions later on in life. And of course, the genetic and biological factors, the aging population, which is a problem all around Europe, but it's a big problem on the Balkans and here in North Macedonia. Those are two pyramids of the population with estimations. This is World Health Organization data. It is estimation in 2050 how it will be, and currently in 2023. Typically, a pyramid should be a trapezoid. If in the pyramid of such should be a trapezoid, should have a wide foundation and going steeper in the front. You see that there is instability estimated in 2050. So it might, how should I say, the wind is stronger and it might twist the tree that you can see in 250 due to fertility rates, due to aging population, and due to overall, I would say, in the previous economic factors. Of course, there are urgent things that need to be addressed for non-communicable diseases in North Macedonia, which is, of course, prevalence in the mortality rates. The cardiovascular diseases amount to around 57 to 61 of all deaths, one of the highest rates in Europe. The other one is the cancer, sadly, which is the second leading cause responsible for about between 17 and 21% of deaths. Of course, economic and social impact, it is estimated over 200 million annually, although I think this is underestimation. This is from the World Bank estimations, because you should have also environment, you should have also social costs, which should be included in this calculation. So it's a bit underestimated by my means. If we speak about public health urgency, without intervention, the non-communicable diseases could reduce life expectancy further and worsen, of course, the overall quality of life in North Macedonia. Key challenges in addressing those problems. Only 20% of healthcare spending, this is data from the World Bank, in North Macedonia goes to NCD prevention and control. Prevention and control I speak of. Lack of public awareness. The surveys show that 30% of adults are unaware of the lifestyle risk factor associated with NCDs. Of course, we are continuing with lifestyle and environmental factors, which I showed in advance. One of the highest smoking rates in Europe, over 40%. In Bulgaria is around 38 to 40 as well, especially with the young. Youngs are continuing this bad trend. And the last but not least, as we spoke about evidence-driven policies, we can speak about also data-driven policies. There are data limitations. The North Macedonia lacks comprehensive national NCD data monitoring system, making it difficult to assess and track the impact of interventions effectively and on time. This also is partially for my country. I can speak about it. So, medicines reimbursement. The chief of the National Health Insurance Fund already spoke of that. There was an outdated positive list, excluded many treatments. It was updated only on 10th of October, as I read in the strategic documents. But now, as I heard, it will be in continuation. It will be opened up for more generic, original, biosimilar, and biological medicines as well. High out-of-pocket costs, which I spoke about before, around 42% is out-of-pocket payments for medicines. Limited access to innovation, no HTA. HTA is important in order to reduce the cost, not to induce them, but to reduce the costs in the future. And regular updates are required, of course, establishing HTA body and improving financial protection, which is panic reimbursement towards to combat costs. Let's go here. There is a nice graph because I spoke about aging population. On the left side here, you see that governments are spending ever more on healthcare for aging populations. You see every trend on the right side of on the left side of the slide is going upwards. And of course, you can see also the tax burdens are at near high records in almost all countries. This is a comparison in between those two. Here I want to say that correlation does not necessarily imply causation, but typically all tax burdens in the past couple of years are due to social, so due to aging population, pensions, and also increasing costs in healthcare, because the older you get, the more care you need. And there are some diseases that can be, how should I say, if you speak about dementia and if you speak about mental diseases, so there are some diseases that even if you treat them, you cannot return the person back to the economy to work. He's already, it's deteriorating his overall condition. So this is, speaking of strategy, this is Sun Tzu thinking about NCDs when speaking about strategy. If you know the disease and you know yourself, you need not to fear the outcome of 1,000 checkups, but you neglect your own screenings, prepare for defeat in every battle. This is The Art of War Against Non-Communicable Diseases, which is his second tome after The Art of War. So the other thing is strategy, development of an NCD strategy in North Macedonia. You already have your health strategy until 2030, but there needs to be a political stability and political coalition in order for this strategy to be developed and followed up at every step. Otherwise, it's just going to be a nice written paper by expensive consultants and wouldn't have the effect it's set as a goal. So prioritize cardiovascular diseases, diabetes, respiratory diseases, and cancer as they're one of the main factors for non-communicable diseases that are factors for worsening overall health in Macedonia. The other thing is developing a national cancer plan aligned with the EU standards. Every country in the EU was obliged to develop a national cancer plan, and in order for there to be a drive, a common European drive, it's probably a good idea to develop one here in Macedonia, but as I said, one which is well-funded, because in my country we developed a very nice plan, and now let me show you the funding for it. Currently, 2 years now, the funding for the National Cancer Plan is zero. So push the politicians, push the government to fund those plans and strategies, otherwise you wouldn't have the outcomes you set there. And another quote I wanted to put, this is from Mr. Eastwood from the movie Dirty Harry. You gotta ask yourself one question. Do you feel healthy enough? Well, do you, punk? Go get that checkup and make my day. There needs to be a push from the governmental authorities, from the patient organizations, from the other NGOs, in order for patients first to understand that there is a need for investment of their time in order to them to reach early diagnosis or to prevent disease from happening. Information campaigns. Everyone has phones nowadays. There are applications that can be developed in order to push forward patients to go earlier and to be checked up earlier, and the cost for them, the cost, and for their families, the cost to be lower in order to succeed more in life, of course, to add up to the GDP, say, as an economic unit, rather than go late when the disease is already spread and it's a much heavier economic, health, and social burden for the government and for the payers. So, action. Adopt comprehensive national strategies for non-communicable disease. Leverage epidemiological data. We'll speak of data later on in the panel. Sustain investment in NCD prevention, treatment, and monitoring. Why investment? Because it has good returns later on. Sadly, if we're speaking about some people, we'll say, some people who are taking decisions from the political side, they have a short span of how should I say, political life. That's why they like the results to come faster, and strategy for them is more or less inconvenient when they have to go to election every 4 years or every 2 years or every 6 months as we do in Bulgaria. So yes, sustain investment, establish accurate and comprehensive patient registers, which is already was spoken of by the chief of the National Health Insurance Fund, and develop patient pathways and care models. Of course, at the end, do not forget, over-interference in people's lives is not so good. We shouldn't be strongly pushing for bans, etc., because the government that raises the price of beer inevitably falls from power. This is from Jaroslav Hasek, is the author who wrote the famous novel about Švejk, the soldier. There is the thing called Laffer curve in the economy, which means that you get returns on increased taxes until a certain point. If you speak about excise taxes, once you reach that point, after that the increase of the tax, how should I say, does not have the same returns and actually falls down. So be careful with taxation, because taxation sometimes helps contrabandists. It helps also people wouldn't say helps, pushes people to high taxes. So this is an important piece that should be always remembered when we speak about taxation and excise taxation as well. So thank you very much for your attention. And now I would like to invite on the stage for the panel that we're going to have now, Mr. Igor Nikolov, who is healthcare advisor to the Prime Minister of North Macedonia. Please, Mr. Nikolov. Ms. Elena Kiosevska, specialist for social medicine, public health, head of the Department of Health Promotion and Monitoring Diseases, Institute for Public Health in the Republic of North Macedonia. Mr. Steve Morton, who is public health specialist from England, UK. And Mr. Ivica Belina, who will be on the screen because he wasn't able. Yes, welcome, Mr. Belina, President of the Coalition Association in Healthcare, Croatia. Okay, let me just have a seat for everyone to. Great. So my questions will be in English. Some of the answers will be in Macedonian. You have a simultaneous translation. I'll just ask the participants, due to time constraints, to be brief and concrete, and of course positive in their answers, that they're going to invest in healthcare, etc., etc., etc. But this is only a proposal from my side. So shall we start? So the first question to Mr. Nikolov. Mr. Nikolov, what are the primary priorities and objectives of the government regarding the prevention and management of non-communicable diseases? And to what extent they are aligned with the European developments and trends, considering that the EU level intensive work is underway on policies for non-communicable diseases, i.e. the cancer plan, and now that they're developing a plan for NCDs?
Thank you. At the start, thank you very much for the invitation and for the questions. We spoke with Professor Kiosa that we are going to answer on Macedonian, so I will transfer on Macedonian. Hopefully it will be comfortable for the audience. Ова прашање е прилично интересно и вака важно и значено. Морам да кажам дека владата од кога е дојдена на сцена последниве 100 дена, а и предходно, приоритет беше да се, особено во здравството, да се мапираат сите оние проблеми и сите оние недостатоци и дефекти кои што постоја и кои што ги наследивме. И тоа е наследено вака во известен период од повеќе од 2 декади. Во овој период од 2 декади со оно што се соочивме сега и денес е дека имавме една кадровска политика која што е навистина вака проблематична. Доколку се распрашате во земјата, сите сакаат да бидат гинеколози, хирурзи и на дерматовенерологија да бидат работени. Така да кадровската политика ќе ни биде и ние приоритет, и во моментот владата спрема сериозна активност на ангажирање на сите еден тип на приватни специјализанти кои што ги имаме, веројатно, не знам во Бугарија дали сте чуле за таква терминологија. Тоа е да секој сака да специјализира тоа што ќе му е желба и е малце вака проблематично заради тоа што не се наметнува директно на здравствениот систем.
Вториот приоритет што ние е развивањето на скрининг методите, бидејќи имаме некаков скрининг, но скринингот секогаш треба да биде подобар, да биде подобро развиен и да биде посоодветен, заради тоа што без добар скрининг не можеме да добиеме соодветни податоци, а без соодветни податоци не може добро да се планира и не само податоци, туку добиваме и начин на кој што пациентите ќе ги третираме. Неодамна имавме средба со Светска здравствена организација, каде што во исто време ни посоветува, ако па само се нафрлите на скринингот, ќе добиете голема бројка на пациенти кои што може би треба да се третираат, а вие ќе немате капацитет да излезете опресред на онаа бројка, така да потребно е да се развиваат во исто време, значи паралелно сите овие три нивоа, сите овие системи кои што, сите овие делови кои што би го приближиле здравствениот систем до популацијата. И на крај би сакам да кажам дека потребна е поголема стимулација за персоналот, бидејќи имаме персонал кој што заминува од земјата, посебно средномедицинскиот персонал, посебно матичните лекари кои што се вака делегирани или сакаат да се преместат, односно да добијат позиција во јавното здравство или во централизираните големи болници. Сите би сакале да работат во голема болница, заради тоа што можеби таму чувствуваат безбедност. И тоа ни прави навистина сериозен проблем на онаа стратегија која што се развива и во европските планови за децентрализација и за приближување на здравствената грижа до пациентите, односно поголема достапност до пациентите. Сега ги знаеме бројките за овие незаразни болести, non-communicable disease, како што ги викате. Ние денеска живееме практично после една голема пандемија, како што беше ковидот, живееме во пандемија на хронични болести. Пандемијата на хронични болести, бројките покажуваат за, например, за диабетот, дека во 2050 година бројката ќе биде навистина голема и околу 80% пациентите ќе бидат во земјите кои што се во развој, како што се Македонија и Бугарија, да ја спомнеме и така натаму. Така да ние се спремаме, значи, за еден живот во здравствените системи, треба да ги подготвиме за едно функционирање во пандемии на хронични заболувања. Со оваа пандемија на диабетот би ја нафрлили и пандемијата со која што јас се занимавам, хронична бубрежна болест. Бројката на пациенти со хронична бубрежна болест е голема, но тука ја спомнавме исто така и кардиоваскуларните заболувања и секако како втор причинител за смртност во земјата го спомнавте и ги спомнавме, значи, малигните заболувања, односно канцерот. Неодамна со директорот на фондот бевме во еден состанок каде што потпишавме така наречена декларација за подобра и поголема пристапност на третманот за канцер пациентите, која што представува дел од некаква европска стратегија и се надеваме дека во иднина Македонија како candidate country ќе биде вклучена во некаква или било каква активност со оваа европска стратегија за подобра пристапност за третманот на малигните заболувања. И само со последново ќе завршам, и малигните заболувања стануваат практично хронични заболувања со кои што луѓето долго треба да живеат, се соочуваме со феноменот на нарушено ментално здравје кај овие пациенти, потребно е име психолошки сапорт и сето тоа е многу важно да ги подготвиме здравствените системи. Вака ви благодарам. Може би го поминав времето. Sorry?
Зашто пациентите не се били
They were involved in the declaration. Yeah, they were involved because there was a lot of I don't know, there were several patient organizations which were present in Bucharest. Around 10 or 15 patients organization.
Please, questions afterwards, please.
Yes, but you can check that there were patient organization.
I'll ask for question afterwards. We can have afterwards because we have.
I'll give you information later if you want to. Okay.
Thank you. Thank you, Mr. Nikov. To Ms. Kosovska, considering the recent national workshop to strengthen collaboration to address risk factors for NCDs in North Macedonia, how would you assess the current state of cooperation among the stakeholders of these issues, stakeholders taking into account everyone in this room as well? What do you see as the most important next steps to enhance the cooperation in order to effectively assess the risk factors for NCDs? Hvala.
Благодарам на прашањето. Пред се сакам да се заблагодарам на Американската стопанска комора и особено Комисијата за здравство за поканата и честа што ми ја укажа да бидам панелист на овој многу значаен настан со цел да се направи нешто повеќе во превенцијата на хроничните незаразни болести. Точно е тоа дека оваа година во организација на Светската здравствена организација се одржа на 9 април работилница која што имаше за цел да ги собере на едно место сите заинтересирани структури и инволвирани структури во превенцијата на незаразните болести со цел да се изнајдат нови начини за превенција и секако крајната цел да се намали морбидитетот и морталитетот од незаразните заболувања. Имено се донесоа повеќе значајни заклучоци на оваа работилница и во контекст на прашањето за како да се подобри соработката меѓу структурите кои што се дел од тој комплекс на институции, организации и слично, пред се постави целта дека ние треба да ја следиме стратегијата на Светска здравствена организација за едно здравје. Тоа значи дека сите структури на сите нивои, во сите сектори во општеството треба да бидат дел од тој процес. За таа цел се предложи да се обнови во државата Националниот совет за јавно здравје, што е регулирано со Законот за јавно здравје пред неколку години и за жал неговата работа во еден период престана. Исто така со тој Закон за јавно здравје се регулираше конституирање на совети за јавно здравје во сите општини во државата. И можам да кажам дека дел од општините го испочитуваа законот и се формираа такви совети за јавно здравје, додека во останатиот дел се уште не се конституирани и не функционираат. Но, исто така, многу важен елемент беше да во рамките на Министерството за здравство се формира специјална национална комисија за незаразни болести, во која што ќе бидат представници или членови, представници од Сдруженијата на пациентите, од Министерството за финансии, економија, здравство, Фондот за здравствено осигурување, Институтот за јавно здравје, како и представници на меѓународните организации, Светска здравствена организација пред се, бидејќи таа навистина се грижи многу за здравјето на сите во светот, но исто така многу важен дел би имале и Министерството за локална самоуправа со општините. Значи, еден компрехензивен пристап во креирање на политиките за превенција на незаразните заболувања. Сметаме дека ваквиот пристап компрехензивен се опфатен на сите заинтересирани структури, не само од областа на здравството, туку и пошироко, ќе биде можност да таа комисија го следи здравјето на луѓето, меѓутоа и на Националниот совет за јавно здравје, кој што по план е да биде во рамки на владата на нашата држава, да биде моторот или координаторот кој што понатаму ќе работи на подготовка и на специјалната програма, односно стратегија за превенција на незаразните болести, после која би следело подготовка на акцијски план за спроведување на стратегијата, а структурите на регионално и локално ниво би биле имплементатори на таа стратегија и акцијски план. Благодарам.
Thank you. So far we spoke about the institutional involvement, but what about the report also spoke about the involvement of the business community as a stakeholder in this whole process? What about the involvement of the business community?
Навистина многу ќе биде значајно и учеството на бизнис секторот во поддршка на сите овие наши владини ангажмани и потреби да се справиме со незаразните болести. А јас можеби само ќе дадам некои конкретни примери во интерес на времето за кое што сме тука. Со тоа што, да речеме, во делот на храната и исхраната. Прехранбената индустрија може да биде вклучена во производство на производи кои што содржат помалку сол, помалку шеќери, помалку масти. Понатаму, во делот на физичката активност, за да се промовира физичката активност на работното место, предлагаме да во секоја компанија менаџерскиот тим обезбеди услови да вработените имаат можности за да се рекреираат со физички активности, но исто така и да има обуки или можности за ослободување од стрес на работното место. Тоа се интенции современи во препораките на Светска здравствена организација. Јас лично присуствував во една компанија во Лондон, каде што тоа на лице место го видов колку малку чини, а многу дава ефекти, затоа што се инвестирало во опрема, фитнес опрема, вработените си одат, си се рекреираат во дозволеното за тоа време и буквално како обновени се враќаат на своето работно место, освежени и задоволни. Од друга страна, во делот на превенцијата на тутунот, употребата на тутунот и тутунските производи, предлагаме неколку мерки. Имено би требало да се ревидира Законот за заштита од пушење, во кој што би требало да се вметнат и мерки за забрана на пушење на електронските цигари и другите видови на производи во затворените места, јавни простори, да, меѓутоа во работните колективи, во училиштата, во училишните дворови, во здравствените установи, да не се употребуваат овие тутунски производи. Исто така, предлагаме да на кутиите на цигарите и другиот вид тутунски производи, освен предупредувањата за штетноста на цигарите и другиот тип на производи по здравјето на луѓето, да се стави и СОС телефонскиот број, кој што би бил за можност луѓето кои што сакаат да се откажат од пушење, таа можност да ја имаат, заради тоа што новата директорка на нашиот Институт за јавно здравје, асистент доктор Марија Андоновска, ја прифати мојата идеја да отвориме советувалиште за откажување од пушење со СОС линија, на која што ние ќе ги даваме советите пред се за оние кои што не се големи зависници од тутунот И така да таа SOS линија биде на секое пакло од цигари и друг производ. Во делот на алкохолот, сметаме дека многу посериозен треба да биде надзорот над продавањето на алкохолните пијалоци, бидејќи јас во моментов сум координатор на едно истражување, а и бев во пролета, за употребата на тутунот, алкохолот во училиштата. И верувајте, бев многу разочарана кога самите деца, тоа се од основно и од средно училиште, ми кажуваа дека родителите ги испраќаат нив да им купат цигари или алкохолен пијалок, а за жал продавачите не ги враќаат заради нивната малолетност. Тие се под 18 години. Значи, мора тука државата да превземе посериозни мерки во надзорот над тоа се пазарната инспекција, здравствената инспекција, трудовата инспекција. И уште еден предлог имам во овој дел, дека може би треба да го превземеме искуството од Република Словенија, кои што ни рекоа во таа работилница дека имаат направено во рамки на Институтот за јавно здравје една софтверска апликација Здрави општини и каде што се поставуваат најсовремените информации за одржување на здравјето и превенција на ризиците по здравјето. Така да и тука може бизнис секторот да помогне на јавното здравство да поддржи, дали финансиски, дали со експерти, некоја таква иницијатива. Па сега би било за сега доволно. Благодарам.
Благодарам и аз. We spoke about good examples from the UK, so now my next question is to Mr. Steve Morton. What good practice to reduce NCD from elsewhere as a shared knowledge could North Macedonia adopt to strengthen its own efforts in this fight? And what international collaborations could support the government in developing better and more comprehensive NCD policies?
Thanks very much. And I'm really pleased to be here because I've visited the Balkans for the last 20 years, and I've looked at the health issues, and I've thought, well, what can I do to help some of the health issues in the Balkans? So I'm really, really pleased to be here. And just to add, that's only 4 years less than I've been working in public health. So I think let's start, only because it happened really recently in the UK, and when I say recently, Monday, where the government tabled new legislation. And it is the big step forward in reducing smoking. Introducing that legislation now, stating that anybody who was born after 2009 or from 2009 onwards will never be able to legally buy tobacco, rolled products or cigarettes or cigars in the UK. They can import it, but they'll never be able to. So every year they get older, they will not be able to do it. And we say that as a country that was once a major tobacco manufacturer, major tobacco importer, with 70% of the adult population smoking. We've progressed that far in that time. So I suppose that says that the journey in relation to public health is always a long time. And as several commented earlier, it's a lot longer than a political period. So you need to get all the politicians on board from all sides to be able to achieve that. And also, really importantly, get the community and the public on board. I guess one reason this piece of legislation was quite easy, because all parties did agree, the previous government originally proposed it, is because children don't have a vote. So everybody else has got an interest, and therefore there's a fear of not doing something where you're going to lose the vote, or that people are actually just vocal anyway as adults. But children don't get that say. So and also we all feel, we don't care what we do, but we do care about the health of our children and the health of our grandchildren. So it's important that everything that we do, if we focus in that direction, be good. Elena mentioned reformulation of salt, sugar, and fatty foods. Absolutely, increasing that is work that is seen around different parts of the world. And one of the bits I can pick up on probably would be, again, would be sugary drinks and a sugar tax, sugar levy, and taken on board, you don't tax everything. This has been really successful initially in Mexico, then moving across the rest of the world, by putting a levy on sugar levels above a certain percentage. Then that has in return has resulted in the large beverage companies reducing the sugar content in their drinks. And the average sugar consumption of everybody in the population, on average, has gone down significantly as a result, both in Mexico, we introduced it in the UK 5-6 years ago, and it's gone down significantly in that time as well. Taken on board that sometimes taxation isn't always the answer as well. And taken on board, if you put the price of alcohol, you're going to lose a vote. Then consider looking at things like the Canadians introduced minimum unit pricing for alcohol. So what that means is by saying, right, you're not going to charge, you can't buy alcohol less than 0.4 euros, 40 cents per unit of alcohol, because that then targets those who are affected most by it. Other people, probably most people in this room, wouldn't be affected by it because they're not buying really cheap alcohol. And if I know the Balkans well enough, a lot of it's produced in the back garden anyway. But it does have an impact in that way. Challenges you have when you have areas with lots of health issues. And in the UK, we have affluent areas, but we also have some very deprived areas with lots of challenges in health, and everything is in the wrong side of the measures. I work with one of those areas, Blackpool, where they got the worst health data in the country. And I turn around to the Director of Public Health and say, which one are you going to, we've got this extra funding for you, what are you going to spend it on? And they give a shopping list, great big shopping list. They say, well, we don't have the money for that. So what do? So let's work upstream. Let's see what we can do to stop the behaviours that are leading to this. How do we design the town slightly differently? How do we put community services nearer to where people live? So then if you have that service, they can reach the treatment much, much quicker. And you don't get that divide, as happens in every country, between the capital and the financial centres, and the rest of the country, and the more rural areas which get most affected, who can't necessarily reach the treatment services. And very quickly on the last part of that question, you asked about international collaborations. I think there are many out there. I'm not going to list through them. Obviously, WHO colleagues earlier would have many around. Lots of them around as well are alliances on particular topics. So rather than saying NCDs, you start looking, well, there are obesity alliances, Global Obesity Alliance. There are ones for alcohol reduction. But then again, there's also one I would really encourage, really Healthy Cities. Healthy Cities run by the WHO. And it brings together areas where they can do that planning and put some of the policies that Elena was talking about together to make it a better place to live, a healthier place to live, which would include cycling paths as well as the other more physical things that you see.
Thank you, Mr. Morton. And now a question towards, how should I say, the biggest stakeholder in all of things, the patient, Mr. Bellina, who should appear here on the screen any moment, like the big brother of all, so following all things and actually the pair in the system, the biggest pair. So, Mr. Bellina, based on your experience with Healthcare Association in Croatia, how do you view the role of a strong coalition among patient organizations in improving outcomes for NCD patients? While there are many well-established European patient organizations, there is room to improve the similar networks at the regional level, probably a Balkan, probably Central Eastern European. What steps do you believe are necessary to strengthen the regional collaboration?
Hello again. First of all, I think that on the national level, strong coalition is, of course, a prerequisite to be actual partner in healthcare system and to advocate patient needs. Sometimes it's much more efficient to have like targeted action And then you can go further larger conservation organizations that have the same problem. And this is the way to avoid just disease-specific problems. And when we talk about the regional collaborations, yes, I think they are necessary because we are aware that Europe is not unique and European Union is not unified, and there are differences between North and South and East and West. And I think that all the actions should be aimed at the larger region of Central and Eastern Europe because we share similar cultures, similar histories, and we have the similar disease burden and health risks burden. But to improve the outcomes, we should track them because none of these countries have actual tracking of health outcomes. And this should be a prerequisite to guide our actions. How can we improve the healthcare outcomes and health outcomes?
5 months ago at ICE for Croatia, if you remember. So as we speak about that data-driven decisions, let's talk a bit about strategies for implementing them. This is a question towards Mr. Nikov. The adoption of national strategies for non-communicable diseases is increasingly a common practice, not only in Europe but around the world, because it's a thread that it's following all of us around. What key components do you believe such strategy could include in your country, considering the overall situation in the state?
Благодарам. Ние чувме и од предходните излагања дека не е проблем да се има стратегија, која што е на хартија, и се соочуваме со феноменот дека стратегиите постојат, но тие не содржат акцијски план. Како ќе се реализира тоа што е зацртано за стратегиите, во стратегијата, така да без акцијски план една стратегија можеме да кажеме дека е бескорисна и тоа треба да биде еден приоритет за сите стратегии кои што ги имаме и кои што постојат. Од пред 2 години мислам дека имаме стратегија за диабет, која што е изгласана, помината на сите нивоа, но не знам како е реализацијата нејзина и планот по кој што таа се спроведува. Значи, за стратегијата ни треба концепт, ни треба визија, но најголем приоритет во нашата земја треба да биде акцијскиот план и неговата реализација. Тој план треба да се состои од точки и подточки кои што би требало да се чекираат, да се штиклираат и некако да се реализираат. Сега можеби не се реализираат заради тоа што чинат повеќе и така натаму. Но сепак генерално за овие незаразни болести приоритет треба да бидат 2 гранки во стратегијата, односно превентивата и куративата. Во превентивата треба да се направат стратегии за скрининг и за превенција, кои што треба, уште еднаш ќе повторам, да бидат со акцијски планови. А во куративата ни се потребни план за соодветна модерна терапија која што ќе биде достапна за пациентите. И тука еве јас да го спомнам чекорот кој што го направивме го правиме во блиско минато и активно и сега, тоа е обидот за дисперзија на третманот за онколошките пациенти, кој што вака не е едноставен заради тоа што има една навика на инерција, кој што колегите од натрешноста често пати не се согласуваат да ја следат тактика за дисперзија и често пати пациентите непотребно се упатуваат централизирано да ја земаат терапијата во големите центри. Со еден збор, за заклучок би кажал дека кај незаразните заболувања превентивата е приоритет заедно со другата гранка куратива, но нас како влада, како популација, ќе ни биде приоритет да имаме акцијски планови и секако да имаме нивно реализирање. Стратегии без акцијски планови се практично мртво слово на хартија, кое што стои и може да се нареди во фасцикла.
And of course, the government to follow up on them and active institutions on the side of the country. Active administration, you can say.
Yes.
My next question is again towards Mr. Bellina. How can patient associations, because there was also asked from the public, patient associations support the development of the implementation of strategies addressing those NCDs? What is the role and how can you help?
Well, there is always this richness experience and maybe a bread of common reason because some of the things are not actually applicable. I will say here that we in Croatia have perhaps the best law on smoking cessation and limiting of use of tobacco products in Europe, but we are not implementing it. So we have the possibility to have declared the non-smoking zone in cities, and there isn't a city in Croatia that did it, and we blame the tourism for it, which is not actually true. And there need to be a strong political will to do something like that. And now we're all again changing this, and again nobody actually asked us how can this be improved and how can this be feasible in real life. So I think that patient organizations and patient representatives are a key factor in making any of the strategies, but also implementing them, because if you just plan something, put it on paper, looks great, you don't have money to do it, and you don't have action plan, as previous speakers said, it won't happen.
Mr. Bellingham, going towards the next step, when we're speaking about strategy, action plan and everything, it's a map with dots, but we need to connect the dots, and to have an overall picture, we need data for that. So about patient registers and data, Ms. Kiosevska, what role do data and patient register play in improving the quality of care for patients with NCDs? I'll ask you for a structured answer, because time is fast.
Благодарам на прашањето. Значи, во нашата држава имаме закон за евиденции во област на здравството и според тој закон сме должни да водиме 34 регистри за одредени болести и состојби. За сега имаме направено напори и веќе тоа е во тек да се водат регистрите за малигни заболувања, за дијабет, за хронична бубрежна инсуфициенција и регистарот за кадар во здравството. Што значи дека во оваа област ние сме свесни дека без солидни податоци не можеме да креираме и правилни јавноздравствени политики. Со оглед на тоа, Министерството за здравство формираше посебна единица, Управа за електронско здравство, каде што всушност се воспоставени темелите на електронското здравство со цел да биде тоа еден дел од интегрираниот информатички здравствен систем во државата. Соработката е добра меѓу Министерството, Управата за електронско здравство, Фондот за здравствено осигурување и Институтот за јавно здравје со 10 центри за јавно здравје. Меѓутоа, како и во секоја работа, така и овде подобрување треба да има, за што и говореше директорот на фондот. Значи, соработката мора да се подобри, за да можеме да добиваме и солидни софтвери, но тие софтвери мора редовно да се апдейтираат согласно на новините во медицината и потребите во здравствената и политика. Од друга страна, може би поради некои системски проблеми, евиденциите на состојбите во рамки на примарна, секундарна и терциерна здравствена заштита не се на задоволително ниво. преоптеретеноста на докторите со прегледите, диагностиката, упатувањето во повисокото ниво и слично, како и можеби некој организацијски проблем, што тие се согласно законот само еден доктор и една сестра во рамки на здравствената организација, може би тука нешто треба да се направи промена. Мој предлог беше да биде еден доктор со две сестри, од кои што едната ќе биде ангажирана во интервенциите, а другата да работи на статистиката. Со тоа мислам дека и ќе се подобри и внесот на податоците во регистрите. Инаку, мислам, одговорните во управата за електронско здравство во изминатиот период навистина направија големи напори да тоа добро профункционира. Сега нешто што треба можеби да се подобри, тоа е да освен јавното здравство, со тој интегриран здравствен систем биде опфатено и приватното здравство, ама мислам на приватните болници, не на приватните здравствени установи во примарната здравствена заштита. Тие добро си ја вршат работата. Меѓутоа мора да имаме еден навистина таков пристап, сите здравствени установи во државата да бидат дел од тој систем. И мислам дека тогаш ќе биде секако дека и контролите во внес на податоци, контрола на податоци зависат и од човечките ресурси. Например, нашите 10 центри за јавно здравје кои што имаат обврска да ги контролираат податоците што се во мој термин, се многу слаби. Нема доволно човечки ресурси, па тука исто така постои можност да се нешто со новите трендови, нели, во политиката од новата влада направи, да се поддржат кадровски центрите за јавно здравје. И тогаш и контролата и ќе доведе до подобар квалитет на податоците, па анализите кои што ќе се прават пред се во Институтот за јавно здравје и другите одговорни институции, ќе биде секако анализата поквалитетна. Благодарам.
Благодаря и аз. So United Health Data Space for all of the participants in the healthcare system, if I can unite it in one point, I believe. So speaking about data, so with the development of the healthcare, there is other sector of the healthcare system, which is the consumer healthcare. And this is a question for Mr. Morton. How do you view the role of digital technologies such as smart watches, personal monitoring in managing non-communicable diseases? What added value do they have?
Yeah, I think that works two ways. There's the side where the health services are going out to help people, and then the side where the people are voluntarily giving health services data and giving the government data. That one latter came very clear during the COVID pandemic, when lots of governments were using Google data and Apple data to monitor where people were moving, and see how far from home were people moving, how many people were staying at home, and that sort of information became very useful. And I've used the same data. I carry out health impact assessments I review the health impact assessments of major developments, such as power stations, railway lines. And looking at those, and roads, and one of the things I look at is the Strava data, because people record where they walk and cycle. And they'll tell where they walk and cycle. We can then say, well, actually, that's the impact. If we put a road, we put railway across that community, we're segregating that community, and we're contributing to poor mental health. So we already have that available, and that's there. Then the other side is, and when I started working in pathology laboratories in the 1990s, we were using point-of-care analysis machines, which were really good in the 1990s. So they're really, really good now. And that's come into the use of being on the watch and other devices. There are places now going out and using watches and other devices to be able to monitor, particularly those recognising where primary care has recognised people who are at risk of cardiac disease or diabetes, to start using that digital technology and giving that or subsidizing that and then recording that back. So it's constantly monitoring the patient, feeding that information back to the health service, or probably to Google or to Apple or someone, who then informs the health service, and the clinicians are able to respond. If the levels are elevated or too low, whatever it might be, clinicians can then respond early and provide that information. And it might be monitoring at what point do you start providing statins, or monitoring the performance of statins in the community, and without having to go to regular checkups to check how that's going. Just one quick other thing from there, which isn't even a watch, it's just a device on the phone or an app on the phone which drives you to exercise more. There are plenty, certainly we've used, and one of the ones I've advocated a lot has been called Couch to 5K, or Sofa, Seats to 5 kilometers, where it starts from somebody who doesn't do any running or any walking to be able to, within 3 months, be able to run 5 kilometers. And it's a simple device that people like playing with because it just reminds you every day, and it chooses the music you can run to. And it's just a stage by stage.
Thank you, Mr. Morton. Now, going towards treatments, I would like to ask the government in the face of Mr. Nikolov, given that non-communicable diseases carry the highest burden and contribute the most mortality, sadly, in the country, and prioritizing the inclusion of modern effective medicines for these diseases on the positive list is essential. What are the opportunities and challenges for including new innovative medicines for the treatment of NCDs in the positive list?
Добро, благодарам за прашањето, интересно е и мислам познато е ние на повеќето од аудиториумот. Она што се случи во последниот период е тоа дека за прв пат после 15 години беа уфрлени, односно беше коригирана позитивната листа на лекови, и тоа со лекови кои што се предоминантно од кардиоваскуларните заболувања. И секако представува еден голем предизвик, особено за земји со буџет како Македонија, за модерна, иновативна, односно листа која што ќе биде со модерни иновативни лекови. Предизвикот, јас во неколку наврати со повеќе луѓе со кои што сум комуницирал и од власта, и од владата, и од институциите кои што се финансиери практично на ова, произлегува дека многу е важно да прво се детерминираат приоритетите и врз основа на детерминираните приоритети биде направен, односно се преземат акции на действување како тоа да се реши и да се коригира. За почеток би рекол дека имаме еден начин на финансирање кој што се разви во Македонија, веројатно, мислам сите го знаеме, тоа е тој conditional budget или условно финансирање на лекови, кој што беше предвиден за времен начин на обезбедување на потребните медикаменти, но кај нас одвремено некогаш често пати се случува да стане трајно и продолжено, и се уште имаме терапија која што се финансира, односно се користи од овој условен буџет, но работата е што преговарачката моќ не е точно фокусирана и детерминирана каде да биде, однос на вредноста на сумата која што се троши за одредена, финансиите кои што се трошат за одредени иновативни лекови, иновативна терапија. Секако, последните чекори кои што ги превзема владата даваат еден силен оптимизам, посебно изјавите кои што ги дава министерот за здравство, дека приоритет ќе биде коригирањето и подобрувањето на позитивната листа и ставање на, односно, незиното модернизирање. Секако во тек е процедурата на подобрување на методологијата, бидејќи методологијата беше вака прилично комплицирана. Јас колку што знам има една стратегија која што е развина, има акциски план. Сега работата е до каде сме со овој акциски план за модернизирање, односно за развивање на методологија за нова позитивна листа. Сепак, желбата постои, кога постои желба, веројатно со напори ќе успееме да добиеме некакви резултати.
Благодарам. Thank you. So now, because we just have a couple of minutes, only two sentences, and now end up with Mr. Nikolov at the end, but two sentences from each other for priorities for NCDs for the next period, I would say, until For next year, for the year after, please, 2 sentences from each other. Ms. Kosovska, then Mr. Morton, then Mr. Belina.
Благодарам повторно. Значи, во делот на научните и стручни напредоци во медицината, можам да кажам дека нашата држава секогаш е во тек со промените, се со цел да направиме подобро здравје во државата. Клинички упатства има во државата, тие се изработени од експертски групи и тоа треба понатаму да продолжи како процес. Можам слободно да кажам дека Министерството за здравство ги објавува на својата веб страна, така да тие се изготвени од наши колеги од примарната здравствена заштита и клиниките и тие упатства битно е да се секогаш обновуваат со цел да се следи медицината во чекор, светската медицина и современата медицина.
Благодаря.
Благодарам.
Mr. Morton.
I'll try and keep it short. Keep investing in healthcare, pharma and development. Try to avoid increasing how much you're investing, how much you have to invest in healthcare, pharma and development by investing a little bit more in prevention and making health everybody's business, not just healthcare's business, but making it the town planner's business, making it every politician's business, making it everyone in this room's business and everybody outside in the city. And we can only tackle NCDs if we work together.
Thank you, Mr. Morton. Mr. Belina, concluding remarks?
I would just say that the health of a nation should be understood as a major national resource. And from that point, any kind of primary prevention is not feasible and it's not able to be done if it's not a result of a societal agreement of every part of the society.
Thank you, Mr. Belina. And now as a concluding question, again, towards the government, who has always the final word and the funding at the end, to Mr. Nikov. Based on today's discussion, what initial steps could North Macedonia take to bring about tangible improvements for patients with NCDs, and what health policy commitments are needed from the government, and how can all of us collectively support these changes, both at institutional and societal levels? Thank you.
It's just a few phrases or just...
Yes, it's your... You have more than few because you're the decision maker.
Јас би ги дефинирал активностите и по приоритети на следниот начин. Прво би било подигнување на јавната свест како една едноставна метода, односно едноставен чекор кој што може да се прошири за целата популација. Тоа е многу важно, особено важна е едукацијата на популацијата, како што кажа Стив, дека здравјето треба да биде работа на сите, а не само на здравствените работници и оние институции или компании кои што се занимаваат со здравје. Раниот скрининг и откривањето треба да ни бидат приоритет исто така на сите, особено на владата и на Министерството за здравство, и ние превзимаме посебни почетни чекори за подобрување на скринингот, заради тоа што со подобрувањето на скринингот практично ќе допринесеме да оваа бројка на смртност кај пациентиве од незаразни хронични заболувања релативно биде намалена. Третата точка би било градење на мрежи заедно со заедницата, заедно со популацијата, и повторно оди во правец на она што го кажа Стив, дека здравјето треба да ни биде приоритет и работа на сите, на целото општество, целата популација, да не се оди на доктор само за време на бременост, по бременост и потоа следното да биде кога ќе се случи некоја тешка компликација. И на крај, овие политики во превенција треба да резултираат со подобрување на куративата, а таа може да се случи со кадровската политика, која што треба да биде квалитетна и со стратегија. Како што кажа професорката, недостасуваат луѓе кои што би се занимавале во центрите за јавно здравје со оние податоци со кои што располагаме, за цел да имаме подобро планирање, Никој не сака, повторно се сведува на она што го кажав на почеток, епидемиологија никој не сака да работи, сите сакаат да бидат гинеколози, хирурзи и кардиолози. Може повтор пат го кажувам, но се извинете ако претерувам. И секако зајакнување на кадровските капацитети и во министерствата, односно во Министерството за здравство, бидејќи скрининг програмите, овие комисии кои што ги набројуваме, сами од себе не можат да дадат производ, доколку во нив не се вклучени најквалитетни луѓе кои што можат да дадат производ и соодветно мислење. Ви благодарам.
Јас благодарам. So this is about the second panel. Благодарам за поканата, драги браке, сестри. It was a pleasure. It was a pleasure to have this talk, and hopefully it was a pleasure for the public as well.
Okay, so it's time for a real break. We are having together, and we are getting back.
Button.
Okay, Arkady, thank you so much.
No
Panelists,
problem.
thank you so much as well. It's time for a real break at 3:10.
Работа или? Работа.
Слушалица. Оцеяна Македон. La 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 la.
Sorry? Can you check the mic?
Sing.
Perfect.
Не знам, ми рекоа дека ја пуштам. Пуштам. Се извинувам за техничките проверки на почетокот. Уште еднаш, welcome back. We are here now after lunch, relaxing a little bit on the third panel of the third conference of Healthcare Committee of the AmCham in Macedonia. We have a very interesting morning. We heard a lot of interesting and valuable information through the previous panelists and a lot of questions and answers that we hear, and we understand that everybody in our country, all the factors in the country are very interesting and very eager to start and to improve the healthcare system. So on this journey that, as we understand, it will be a hard path to reach what we need, we will need an expert know-how and a positive experience from European countries and neighboring countries. So for this purpose, we invite here, let's start with Madam Ms. Vita Godec, Managing Director of Lenis and Medical Pharmacia for Central and Eastern Europe. Welcome. Mr. Hoti Kliti, Executive Director of Novartis, situated in Tirana, but responsible for the region. And Mr. Sava Todorov, Associate Director and Policy and Communication in MSD Bulgaria, Albania, Kosovo, and Montenegro and Macedonia, of course. Nice to meet you. And so we will start with the first question, of course, with the lady first. Let's see, what do you think and what lesson can North Macedonia learn from how reimbursement lists are structured in other countries, I mean in European countries, as Slovenia is a European country, to strengthen its own system and enhance patient access to essential medicines.
Thank you for inviting me. I'd like to start with saying that there's inequity all over Europe, not just between EU countries and non-EU countries. And with that in mind, I'd like to ask Vladimir to pull up a stat. It's the only chart we have in this section. So the top chart shows that out of the 147 new medicines, it's from the year 2023, and it's IQVIA data, that were registered in European Union, 147, so all of them were available in Germany. And then as you go toward the right-hand side, less and less of them were available in other countries. So for example, Slovenia, where our company is headquartered, had 70, I think it's 74 or 72 available. Then Croatia, 40-something. And then if you look at this hand side, so the non-EU countries of the Adriatic region or the Balkans, are in the tens, and that's quite a difference. It's a 15 times difference from Germany, and I think that's very worrisome. So our company works in 8 countries, besides Slovenia and Croatia, which obviously are EU countries, also in Bosnia, Kosovo, Montenegro, Serbia, North Macedonia, and Albania. And we see vast differences in the reimbursement systems in these countries. I'm personally most familiar, obviously, with Slovenia. And despite the fact that we're a small EU country, we still have, well, let's say pluses and minuses. The pluses are that if a medicine is registered by a CP procedure, we get registration relatively fast. And as far as reimbursement goes, which is the topic of this, third panel today, we also have very different mechanisms besides the regular reimbursement procedures that allow innovation and new medicines to come to the market fast. What's particularly good is that we have regular monthly committee meetings at the National Health Insurance Fund, and that these meetings are transparent, cross-functional, that there are people from Health Insurance Fund, Agency for Medicines, Ministry of Health, and so on participating.
So you, sorry to interrupt, every month you have...
every month, yeah. And it's the same in Croatia, and then as we go towards, in Serbia, North Macedonia, it's yearly, or even, as we saw earlier, once in 10 years or 5 years.
Okay, we just started.
Yes, yes. So, yeah, we have some good practices, but obviously these took times to develop. But they're there, and because of them, those results show that we have access to more medicines than otherwise.
Okay, thank you. Mr. Hoti, how are the things going in your country, in Albania? And
first of all, thank you very much for being in this panel. It's an honor for me. By background, I'm a doctor, physician, so in a way, understand the needs of the patient, and as everyone here. So I'll go a little, further. From 48 products are registered from 19 to 22 in Europe. If Germany has available 46, in Macedonia are available only 7. So does it mean that we really need to be focused for in these terms of innovative medicine, innovative products, and we have to find the way how to proceed? Thanks God, things are changing, and as it has been mentioned from the speakers before, 15 years it has been no new reimbursement list, and actually we have a new reimbursement list, and that is a really great news for patient first, but then for the companies. For innovative companies needs to be more space, because that's the innovative products that needs to be present and be available for a Macedonian patient. If we go back to Albania, as you see from the graph, is more or less the same. The only thing that is changing is the fact that reimbursement is every year. We have a meeting that is every year. And the fact is that despite that it's a regulatory that needs to be updated and need to be more as a reference to health technology assessment, because it's not at the level that European countries or neighboring countries are, but I think we'll discuss later on. So it's 1 per year, and the possibility that innovative medicine to be present at the list, it's has more possibility, has more access. And I'm talking for my company that we have access for the innovative products. And lately, this year, we implemented a management agreement that through that, we have possibility to have access for our innovative products. What else I can add for the reimbursement list is the fact that we are in the leading position as innovative companies, and each year we revise the prices, and the prices, of course, will go down. So that creates the space for the generics to be present. So we introduce the innovation, and then is the cycle, then the generics will take over. So it's important that health professionals to have access to innovative products, and not only as product, as innovation, but as a package, because that is important, that that will support and will develop and go in the other level will go the knowledge of the health professionals in Macedonia in treating the patients. And that is so important, the fact that we need that healthcare to be to the other level, because it's an investment. It's not a burden. It has been said, and I want to state again this fact that it's really an investment, and we need, that Macedonian patients to be treated in Macedonia and not out of pocket or to go outside Macedonia, because that's why we have the obligation and the responsibility, all together to find the ways. I know that is not only one way that is just to increase the budget, because director of fund is here and will say, okay, something else, only the budget, no, but are a lot of possibilities. And we have, as multinational companies and innovative companies, we have a lot of mechanism to bring innovation in Macedonia, and not mandatory through the price or the higher budget. But we need to be, and I'm happy that actually the situation, let's say, has changed. The mentality of the government is different, and we saw that, and from the speech that Mr. Nikolov made, and yeah, that's more or less, the experience that it's something that we can copy paste and we can implement at least one per year to be this.
Cooperative, and that you could help in building the new ways to enter new drugs on the reimbursement list. Mr. Sava, what is happening in Bulgaria and the region?
I think colleagues covered more of the region, but I would like first to say thank you for the opportunity and for inviting me. And I would like also to say that we had a great session in the morning focused on the prevention. I would just retrospectively go back and say that I think prevention is the most important. If we're talking here about access to treatment and treating patients, but the best option is for those people not to become patient at all. So, and I think also Macedonia, there is room for improvement everywhere, but we can also learn from North Macedonia. For example, primary prevention through vaccination in North Macedonia is quite good. So we are also coming not only to share best practices, but also take from North Macedonia best practices. For example, I would say in terms of prevention of oncological disease, like related to HPV, North Macedonia is staying, I think, one of the best in the region. So we're also here to learn, not only to share our experience. Going back to the reimbursement list, and going back to what my colleague showed in the link to the FPA weight indicator and availability. So what you can see from the graph is that countries that have set out regular process, transparent process, they're closer to the EU average. Those ones that are having different type of systems for access of innovation mainly, and especially when it comes to conditional reimbursement or any type of caps, they're moving into the left-hand side and having much less access to innovation for their patients. So for me, it doesn't matter how often the reimbursement list would be updated, because this is a question of capacity, of local capacity, and how feasible that is. But it's important to have a straightforward process that is transparent, and the most important is predictable, because the biggest barrier for innovation to enter in a country by a company, or for a country to be deprioritized in the sequencing of launching new products, is unpredictability. If you have a straightforward process, even if you know that it will take 1.5 years, then this is a predictable process that you can predict, you can plan for it, and you can manage. If you don't have any predictability and you come in a country and you try to launch an innovation, but it will take, let's say, 10 years for reimbursement, or it will have just few patients having access, we are far from equity, and this is creating a huge barriers. Talking about Bulgaria, Bulgaria is an EU country, and it's easier because there is kind of like for Slovenia, kind of synchronization of the processes. Also, in terms of registration, not that the registration in Macedonia is a problem. North Macedonia is one of the countries that is having one of the fastest registration process, but then what about the reimbursement? So in Bulgaria, the reimbursement list is updated once per year, but there is a straightforward process, how it goes, the submission of the HTA dossier, HTA assessment, negotiation process, and then reimbursement, and then entering into the reimbursement list. So we have predictability. We know if we start working this year, the patients will have access next year. And this we were like in the weighted indicator, FPO weight indicator, Bulgaria was a country that with a very high score in terms of waiting days compared to Germany. So having a straightforward process for the last, let's say, 10 years, we're much closer to the EU average, despite the delays. So when we have very good access, and I would say affordable access, but maybe we talk for the affordability and the way to make it affordable for the patients in the next questions.
We know that in Bulgaria, the posebni dogovori, što manager entry agreements, are for several years implementing, and a lot of products, new products, innovative products are on the market. The patient has access to the innovative products because of that. How you manage it and what we can learn from this experience you have with MEA agreements in your country?
I would say that the definition of access is to have no leave patient behind, and to have the right product for the right patient at the right price. But the right price, it's different for everyone. It's different from a perspective of affordability and willingness, ability and willingness to pay. So for each country, this is different, and that's why this straightforward, transparent process that is established gives you the opportunity also to have a negotiation process. When a new product is entering, there is an obligation that you negotiate a managed entry agreement with the payer, which is in that case the sick fund, together with the reimbursement body that is assessing the HTA, because in an HTA process, you are not assessing the price of the product, but also its value, the benefit that is bringing, the innovation that is bringing, extended expectancy of life, and everything that is consisting of an HTA file. So it works well because you can make in a transparent way. You have the negotiation process when you can negotiate with the payer terms that are so more patients have access to the product, to the innovation, but are like feasible for both sides. And this is increasing the affordability and also the level of access of innovation for the patient. So for me, a setup process for doing so, it's the most important. The managed entry agreement can be different kind. There are many examples in the European countries of different type of agreements. All the healthcare system are suffering and are under pressure because of the aging population, because of better results of the innovation. People live longer, they're longer on treatment. So all the healthcare system are under pressure. So they need to find a way to manage it. And I think this is, at the end, you find that it's much more cost effective doing it that way rather than capping and limiting the access of patient and not having access equity for all the eligible patients.
Ms. Vita, what is the current situation in Slovenia and the countries, Central, Eastern Europe that you're covering?
In the countries we cover, we run several different programs, from named patient basis programs to early access programs. So the drug doesn't necessarily have to be registered to be sold or to be accessible to patients. It can be also unregistered or unlicensed, if you will. So Slovenia in particular, because of its small size and because if the manufacturers want to manufacture local livery, it's usually not profitable, so to say. But we have a very special reimbursement list for unlicensed essential medicines, and we can get them in. We can label them with the Slovenian pillar sticker, and they get regularly reimbursed and sold in pharmacies. And our company has over 30 such medicines on the market, despite our smallness. But we found a way, together with the agency, with the health insurance fund, to get the drugs to the market. But I would say all of these managed entry agreements are basically conditional funding for a while until the drug is registered or until it's reimbursed, which is what we want, because we want to ensure that we have local deliveries. It's easier for the patients, it's more safe for the patients, the control is better, and we want to have regular reimbursement as well. But we know that there's a way to get there. One good thing we also have is a list of essential medicines. So I know that the WHO and also the EMA publish their own list of essential medicines, but those in Slovenia get priority with reimbursement. So that's also one maybe good way how to start, because you don't have to reimburse everything. You, as we talked earlier before lunch, need to have a strategy, need to put some priorities, and then go through the baskets, through the therapy areas, through the drugs, and slowly make traction, because I love the talk and the strategy, but I'm also a woman of action, so I like to see things starting to turn around, yeah, and that's what we do.
Okay. And Mr. Hoti, what specific practices you have in Albania, and what do you think that can be copied
I'll go
here
more
in Macedonia?
simple, because in a way, we have to take in consideration that 50% of the adults has one chronic disease, and Ms. Lodorov says that 27% of them has more than 3. So diabetes, cardiac problems, COPD, etc., etc. So we really need, products for these patients that are the core, of the society, and we have to. And with the aging, that is really important. So we have to find the ways. If we go to the management agreement, are very, let's say, are a lot, and we can go from discount agreements, price reduction for payers, volume-based agreements, risk-sharing agreements, outcome-based agreements, pay for performance, but what we can implement here, and that is the question. We need to make that simple. Simple in order just the fund, the budget, the Ministry of Health to manage, the budget that they have. We know that it's 7.2% of the GDP, and we know how much is the GDP, and the absolute number, we know that it's not big. So with this money, we have to find a way to access these products. And let's go for a really very, very simple ones, and financial one, the discount one is the most acceptable. And of course, together with volume-based. With volume-based that, because director is here, and if I can say, okay, I will give a discount, and he makes the beautiful question, how many patients are? What is the incident? What is the prevalence? And we do not have data for that. So we have data, but we do not have the exact data, So what we can do, we can cap. So for 100, let's say, patients, will be this discount. But if we go more, then the discount will be half of the price. Or because you cannot stop. Because that is the conversation that I have done with the director. How can I say that you have to be treated, you do not have to be treated? So let's find simple ways in order just to implement. We have done the first time, we have done in Albania this year, and I think it has been effective. I think it has been effective. And but in my concept here need to be done. So the who has the money has to sign the contract. So it's not that one signs the contract, the other one, pays the money. So we need one body, some rules, and these rules has to be defined very properly, but simple rules, simple, let's say, legislation, in order just to implement. And in this way, we have to do our job, 1, 2, 3, and the others in the multinational companies, to do our job in order to create possibility that this innovation to come to Macedonia. So I'm for simplicity. Simplicity, because with the simplicity, the fund and who is the decision maker, will not be unpredictable for them, for the budget and for everything else.
Positive experience in Albania with this.
And we put this year more than 50 products innovative products at the positive list with this management agreement. And it has been financial one, discount. Let's say if I want to make more simple.
Mr. Sal?
I agree. I here agree for the simplicity because I said there are different type of agreement that you may choose and you can explore what's working well in other countries. But Klit is absolutely right. For more sophisticated agreement, like pay for performance or any other type of agreement, you need registry, you need more data that is not available. So a simple one that is like price volume most probably is going to be the most applicable and easy implemented. Further on, both building on the data and the capacity, you may improve and see what works well in the country. But maybe the simplest one is to start with.
Yep. Ms. Vita, you have in Slovenia so many years of experience in this. You are satisfied with what is happening there? What is happening in Macedonia? Are you satisfied?
Actually, we see in the whole region that the status with the reimbursement is actually worsening, especially Slovenia and Croatia. It's much more difficult to get the innovative and even generic medicines on the list, which is surprising. I just wanted to mention, you said price, pay for performance. We tried to use this method in Slovenia, and the fund said we don't have the enough people to follow that. So the data is not the problem; it's the people that would then calculate and compare. Because I think these conditional funding mechanisms are there for two things. One is to minimize budget impact, and the second one is to really check if the drug is effective. For some reason, for some innovative medicines in Slovenia, we were able to get first reimbursement in the EU, which was really special. And the fund was really worried, oh, is it going to work or is it not going to work? But at some point, you have to put a number and check the performance. We did it ourselves, and then the fund just checked the numbers. But obviously, if this was in an independent, made in an independent fashion, it would be even more transparent than transparency and business compliance. And I want to mention this is also something that companies that are trying to enter or wishing to enter this region are looking for. So cross-functional, transparent, compliant, clean timelines, clean costs. Yeah.
You mentioned previously the health technology assessment and recent advantages from HTA and what is still in your market, in your country, established, but what are the best practices that could North Macedonia consider adopting to establish the effective HTA practices? We are not there yet. Let's start from the zero, from the beginning, to explain a little bit more.
I think there is a significant progress. There is a process established already from best of my knowledge in North Macedonia. Already some dossiers are already submitted. I think an HTA process is a good one because, as I mentioned in the first question, this is a process that you are assessing not only the cost. There is also the benefit of the product. I would not go to the methodology, ICER, how this is calculated, but it shows the benefit of this innovation and which is the population that is going to benefit and over of the current standard of care. So this is very important, that going back to the morning discussions, that we are talking about health as an investment and not as a cost. And HTA gives us an opportunity to assess the value and the benefits of innovation. What are the best practices, I think, and what is most important? I think one of the time will show whether it's going to be effective as we are expecting, and it will shorten the process, is the joint clinical assessment of the EU HTA. Now it's about to be seen how it will improve the process and how faster it will be for the EU country. But I think it's also again, a matter of capacity. You need to build, the country needs to build the capacity to have an HTA body capable of assessing those dossiers. And once you are opening the process, there will be many. If you need to go and assess and do an HTA assessment for the reimbursement process for all the products, there will be many of those. So you need to have an HTA capacity built in the country. I can say from a Bulgaria history perspective that when the reimbursement process was established and it was established as a process, we started with a simple pharmacoeconomic assessment and budget impact, not having the full HTA process, but it was giving a very good idea for the payer. What is the cost effectiveness of the product versus the available standard of care currently in the country, and what is the budget impact and what budget they need to forecast for those products. So maybe you can start small steps and simpler, and then moving further into the more sophisticated HTA process, together with all the options for the managed entry agreement, or yeah.
Mr. Potin?
Yeah, thank you. In a way, I can say that we are doing, we are almost the same level, and we are pushing, as let's say pharma industry, but there's a concept, or you have to push back or you have to embrace. Now it's kind of like with artificial intelligence, you could not push back anymore. You have to embrace. You have to accept the fact. And if you connect the dots in Macedonia, I heard Professor Elena, Mr. Dr. Nikolov, that said that is e-prescription, connecting with the diagnosis, and there are things that are happening. Studies, clinical studies that are in Macedonia are really very good and are much more better than the region. We do not have a registry that we need to do, and if we connect the dots, then we'll go to health technology assessment. Because what is health technology assessment? Because it's a big word, but it's really very simple. You have just to have, at least we have to calculate and to make 1% of the budget of healthcare for health technology assessment for a body that is at the public health. And the same has been done in Croatia, the same, and it's in upper level, of course, Bulgaria and Slovenia, but I mean Serbia. Serbia has small projects and is doing really very good. And we need to go with a small project. Let's go with a small project. Let's health authorities, decision makers, let's fix a budget, because first of all is the budget and our capabilities. And we have to fix that, I'm talking for Macedonia, of course, and for Albania, but we need to understand that that is the future. We could not push back anymore, because we need to go, what Sava said, that we really need, to begin the first step and need a body to connect the dots. The substance is here. We need just to connect the dots, because I have a conversation, and that is the beauty of this meeting, because you met a lot of very, very nice people and knowledgeable people that said that it was the electronic prescription, but when you go to the hospital or to the what doctor is fulfilling, they do not match with each other, because it was one that it was not filled, the diagnosis properly at the right place. So this is very easy, it's very simple. You have just to plug that cell, that the doctor could not go to the next page or to sign that report, and then he will write the right diagnosis, and it will be the health technology assessment, the body who will gather all the diagnoses, and in the end that will create, let's say, the registry that we really need, because we do not have a real registry for let's say for breast cancer or for multiple sclerosis or for whatever, to be a database that we can use this database. So if we have this database, we will be next level for clinical studies. And if I saw that IQVIA is here, representative of IQVIA, that I have discussed with the guys and said that we can make beautiful things if we have this data. So we need to produce this data, and we need to establish a body to the Public Health Institute to take care only for that. money and capabilities, and then we'll come.
In the previous panel that there will be, it is a idea, it is in the law for a few years that there should be a national health care committee.
need
So the government is working on this. So Ms. Vita, what has to be their priorities? Huh?
Priorities, but I'd like to add one more thing. So starting
Yes,
with a
okay.
simple budget impact is
Okay.
great. It's the easiest way, and just do a pilot project and do it. Don't wait for strategies and for policies and God knows what. Go into action, yeah? But the second thing is the difference between HTA, what is it, and so on, is that it looks holistically at holistically, not just comparison of drug A to drug B, but if a drug B is so much better, then it shortens the hospital stay, that it delays, I don't know, dialysis for 2 years. Calculate all of those costs. It's not just the comparison of a pack of 10 and a pack of 10 of the new medicine. So that's the beauty of the HTA, looking at it holistically. Mrs. Müller said very nicely, it affects much more than just the cost of the pack of tablets or vials or whatever, yeah? Yeah, and don't invent new water, or how is it called? We call it water.
Learn from you.
If there's already an EU HTA form and you're a country accessing EU, hopefully we have now the Slovenian candidate for the commissioner for accession of new countries to EU is being elected hopefully today in the European Commission. It's gonna ease that process then as well. So think like you're already in EU now. It would just simplify things when you will be in EU. And I hope you are soon, and I asked yesterday if I can tell this joke. Yeah, oftentimes in our company, when trying to convince principals, so pharmaceutical companies that are not present here and don't really want to be present here, they have 1 or 2 products. These are too small, too complex markets. And sometimes I say, I wish we were still Yugoslavia, we would be a top 6 market in EU and we would have all the drugs that we would need. But since we are not, we have to go the other way around and get you to join the EU as soon as possible. And until then, find innovative ways how to handle in the meantime.
Okay. Yeah? Let's go with the final wrap-up. We discussed a lot of things here. We know everything. We know what we have to do. We will invite you once again if we need your experience. And let's wrap up like this. Which are the 3 key actions that we have to do to establish a attractive, positive environment for the pharmaceutical companies to come and to register and push all this to have the access to new drugs and better healthcare systems and health population.
The main one is transparency. So business compliance. When foreign companies, for example, US companies, Japanese, Asian companies come here, they hear, oh, Eastern Europe, oh, corruption. So that's still in their mind. Like Eastern Europe, there's still war there. It's similar. So we have to dispel this myth by showing that we're a transparent community, transparent countries, that there's business compliance there. And it goes with this pricing and reimbursement process as well. So these managed entry agreements are in some countries hidden. These are hidden discounts and so on. But if we're, transparent about it, I think that would go a long way. Second thing is speed to market. So each pharmaceutical company wants to launch the product as soon as possible, not only because of financial reasons, but because of patients, obviously, to get the innovative or even in some cases generic treatments as soon as possible. So if you have clear timelines, as Mr. Todorov said, that would help a lot. And then third, which is a maybe creative way, is to think about positioning North Macedonia as a site for clinical trials. Because companies that do that, and I see a lot of doctors nodding and so on, that would be very effective in, if you have patients here that are part of clinical trials, you then get early access programs, you get donations until the drug is registered and reimbursed. So that's maybe another option of looking into it. And it also brings economy into the country. So enhances GDP, brings jobs. So that's maybe one creative way of going about it. Think about it. Yeah.
Supporting? 3.
She said almost everything.
Okay, let's repeat it.
Yeah, if I can add something is that to make clear rules and I abuse today with the simplicity, but I'll say the last time I'll say simple rules, simple regulation, that and transparent, yeah, and of course, yeah, and to follow. And I will build a little bit more with these clinical trials, because I know I have some experience, and it's really great. It's really fantastic. And I would say not only Macedonia, it's almost the same population, White Caucasus, and in Albania and in Kosovo, and it's almost, 6 million. And so it's a pool very, very interesting. I make somewhere a discussion that with the war, Russia and Ukraine, because there are a lot of trials that has been in Ukraine and Russia, now there are not anymore, and companies are looking for other markets. So if we have a beautiful legislation, a simple legislation, but we do not need to ask, somebody if I can enter. Just we need, to click, in the site to fulfill all the documentation, say yes, done. Then, ethical committee, etc., of course, yes, but the basic parts to be done immediately. So these kind of things, and that will make the connections, to go to the next level. That will make these clinical trials, will make the young doctors to get PhD, etc., and will be in the map. Will be in the map. And doctors maybe is not the audience, but doctors will be paid really so substantially that maybe, and the salary will not be something more interesting for them. So we need to understand that this is a possibility and to use, and not only in Macedonia, but in neighboring countries. And that is, at the end of the day, we are the ambassadors to connect each other. We have the obligation, the responsibility, to do that. We are sitting here, so we have to deliver something. Otherwise, why?
Thank you. Mr. Sala, the three
I'm
key
afraid that
points.
they covered most of it, and I'm afraid that I'm going to also repeat some great thoughts from the earlier panelists before the launch. But one thing that I think it's very important also to mention is that the country needs to first to consider and understand what level is the contribution of the sector. So I don't have data for North Macedonia, but I can say that recent research in Bulgaria showed that the whole pharmaceutical sector, including the wholesalers, the producers, the represented marketing authorization holders, all the jobs that all the openings and everything as a contribution from the sector goes to 2.2 from the GDP. With 2.2% of the GDP is huge.
Wow.
It was like, I don't remember in billions, but a huge number. So 2.2 from the GDP is huge contribution. Then there was also additional research on the hospitals, which showed even higher. So the sector is contributing a lot to the economy. So this is the first thing where we need to start and consider the pharmaceutical sector as a contributor to the economy. And for the companies to come and contribute to the economy and to come and stay in North Macedonia, I would go back in the beginning. Predictability is essential. Even not the size of the business, it will come, because from our understanding, and even in MSD, we're saying that the medicine is there for patients. And if we do it right and we deliver the medicine to patients, then the business will come. So it's not even the size of the business, but the predictability. If you can predict what investment you need to do, for how long, and how it's going to work for you, then it's much easier for a company to justify the presence and willingness to help those patients and stay in the country. This is for me the most important thing. And having those processes set up, this transparency that my colleagues were talking about, will help give this predictability and sustainability for the companies to stay. And if I need to add something, I will go back to the Mr. that was an advisor of the healthcare minister, right? he said we need action plans. We don't. We have in many of our countries we do have a lot of great strategies, but they're just on paper and not executed. So as mentioned, you don't need to invent the wheel. There are many practices that can be taken, but just start executing and having an action plan rather than writing strategy that will stay on paper and not executed.
And actually, if I can add, executing in a small sections.
Baby steps.
Baby
you
steps,
reach
and this is what IT engineers call minimum
Agile.
viable product, agile. So we need to think like engineers.
Yeah.
Include the transparency,
yeah,
simplicity,
predictability,
and an action plan.
Yes.
Somebody
Yes,
to actually do
these are
the
four,
work.
but we hope for three. Thank you very much. I don't know if there is a question from the audience, maybe. They are here, they want to say a little bit more, maybe.
It's a great idea, and it would be great to work with the patient organizations on implementing those clinical trials because they have access directly to the patients. I've been involved with Novartis on a global level of implementing such a clinical trial in Serbia. So if it works there, it can work within our region as well. But I do believe, as Mr. Horty said, that it should be regional, not just Macedonia, but on the regional level so we can pull together. And thank you for all that you said. I think, probably one of the best talks that you actually said that you should be accountable for what you're delivering here. Thank you for that.
Thank you very much. In terms of, if I may comment, in terms of the clinical trials, the point was to establish North Macedonia as a preferred country, and this can be done because many clinical trials are requiring Caucasian race to be included in the Caucasian in the clinical trials, and they're looking for countries that this could be more, let's say, put it in a way, more cost effective, and North Macedonia could be a preferred country. And otherwise, the access of the patient for the clinical trial, then it's easy if it is preferred. There are a lot of platforms like Find Me Cure that are linking patients with available clinical trial, so they can have access. But this is also a lot of contribution to the healthcare system. It's a lot of resources behind the clinical trials. And it's also an option to have an early access to treatment. Sure thing, yeah. But
and despite the fact that in Macedonia or Albania, whatever, we are not, let's say, very big teams, but as a backup, we have really big companies that we can use their capabilities to implement here. So I'm just what you are saying. So we need to do that, and we have to push. We need to push, and moreover, and collaboration between the universities. Partnership with universities. So we can build on that, and we can build really beautiful things, really, really good things. Just we need to be small steps and consistent, as you said.
I think that this conversation is a first small step in all those things.
And I'm so glad that it's organized on the platform of the American Chamber, because I think what is also, we were talking a lot about capacity and building capacity, and we know that usually in the institution it's very difficult to have all this capacity and resources. So in organizations like the American Chamber, they're fostering a lot of company, and therefore a lot of expertise is focused, concentrated in the American Chamber. So if the state and the government would look like an organization like the American Chamber and look for a public-private partnership in asking the private sector to support with expertise, I think this will be improving the process and the capacity a lot.
Thank you. I know that we could talk for an hour more, but I think for today we could wrap up the conference. Yelena, what do you think?
Thank you very much.
Thank you.
Thank you, everybody.
Thank you very much.
Jasno. Hvala ti.
Hvala i na vas.
Thank you.